intensitas intelektual. Kuliah saya hanya di 2, tetapi intelektualitas yang disajikan ISPHE waktu itu benar-benar baru saya sadari di hari-hari ini. Bahwa menjadi pintar saja tidak cukup, karena pintar itu teknis. Menjadi orang pintar itu harus sekaligus menyenangkan, itu pendidikan emosional. Nah, cara-cara emosionalitas yang diajarkan oleh dosen-dosen saya itu sangat menyentuh hati.
Kenapa saya memilih UNES sebagai tempat untuk belajar? Karena UNES adalah universitas konservasi dan salah satu universitas yang melestarikan kebudayaan Indonesia.
Layaknya manusia, UNES terus tumbuh semakin dewasa. Peran dan kontribusinya semakin besar bagi Indonesia. Dengan belajar di sini, saya yakin akan semakin dewasa sehingga dapat berkontribusi bagi masyarakat dan bangsa, kini, esok, dan seterusnya.
Buat saya, UNES adalah salah satu perguruan tinggi yang luar biasa, terutama mampu mengangkat kota Semarang ini di kancah dunia nasional maupun internasional. Komitmen yang luar biasa dari UNES terutama untuk membuat kampusnya menjadi kampus konservasi dan bertaraf internasional. Kalau kita lihat di dalam kampusnya, komitmen itu benar-benar diterapkan. Begitu sejuk, begitu luar biasa penataan estetika kampus, sehingga mahasiswa pasti akan merasa betah, nyaman untuk bisa melakukan kuliah di kampus UNES.
Harum luhuring pawetan ing astoniro. Harum dan luhurnya lembaga ini tergantung pada tangan-tangan kita semuanya. Kami memberikan layanan terbaik dalam tridharma perguruan tinggi agar dapat menghasilkan insan akademik yang cerdas dan berkarakter konservasi. Kami terus melakukan inovasi agar UNES terus menjulang tinggi dengan semangat UNES mendunia untuk Indonesia.
Berwawasan konservasi.
Bereputasi internasional.
Rumah ilmu pengembang peradaban.
Mendunia untuk Indonesia.
Saya memiliki keterikatan emosional yang sangat intensif kepada UNES itu. Pertama, intensitas belum emosional itu intensitas intelektual. Kuliah saya hanya di 2, tetapi intelektualitas yang disajikan ISPHE waktu itu benar-benar baru saya sadari di hari-hari ini. Bahwa menjadi pintar saja tidak cukup, karena pintar itu teknis. Menjadi orang pintar itu harus sekaligus menyenangkan, itu pendidikan emosional. Nah, cara-cara emosionalitas yang diajarkan oleh dosen-dosen saya itu sangat menyentuh hati.
Kenapa saya memilih UNES sebagai tempat untuk belajar? Karena UNES adalah universitas konservasi dan salah satu universitas yang melestarikan kebudayaan Indonesia.
Layaknya manusia, UNES terus tumbuh semakin dewasa. Peran dan kontribusinya semakin besar bagi Indonesia. Dengan belajar di sini, saya yakin akan semakin dewasa sehingga dapat berkontribusi bagi masyarakat dan bangsa, kini, esok, dan seterusnya.
Buat saya, UNES adalah salah satu perguruan tinggi yang luar biasa, terutama mampu mengangkat kota Semarang ini di kancah dunia nasional maupun internasional. Komitmen yang luar biasa dari UNES terutama untuk membuat kampusnya menjadi kampus konservasi dan bertaraf internasional. Kalau kita lihat di dalam kampusnya, komitmen itu benar-benar diterapkan. Begitu sejuk, begitu luar biasa penataan estetika kampus, sehingga mahasiswa pasti akan merasa betah, nyaman untuk bisa melakukan kuliah di kampus UNES.
Arum luhuring pawetan ing astoniro. Harum dan luhurnya lembaga ini tergantung pada tangan-tangan kita semuanya. Kami memberikan layanan terbaik dalam tridharma perguruan tinggi agar dapat menghasilkan insan akademik yang cerdas dan berkarakter konservasi. Kami terus melakukan inovasi agar UNES terus menjulang tinggi dengan semangat UNES mendunia untuk Indonesia.
Berwawasan konservasi.
Bereputasi internasional.
Rumah Ilmu Pengembang Peradaban.
Mendunia untuk Indonesia.
Ladies and gentlemen, may I have your attention please? Our agenda is about to begin. Thus, I'd like to inform you several information. Our webinar is online on Zoom for registered participant and live on YouTube in FIK UNES Semarang Official. Please kindly like and subscribe. And please inform your colleague to watch it in our YouTube channel. It is FIK UNES Semarang Official. All the participants should turn off the microphone during the webinar and should turn on the video camera during the webinar. Question and answer are only available during the plenary and parallel session. Any question should be written in the Zoom chat and will be delivered by the moderator. Our webinar has 300 participants in Zoom and over than 300 participants in YouTube channel. Thank you. Ladies and gentlemen, we will watch a short video before we start our webinar. Please enjoy the video.
Bu Mardiana kelihatan lagi makan.
Saya memiliki keterikatan emosional yang sangat intensif kepada UNES itu. Pertama, intensitas belum emosional itu intensitas intelektual. Kuliah saya hanya di 2, tetapi intelektualitas yang disajikan IKIP waktu itu benar-benar baru saya sadari di hari-hari ini. Bahwa menjadi pintar saja tidak cukup, karena pintar itu teknis. Menjadi orang pintar itu harus sekaligus menyenangkan, itu pendidikan emosional. Nah, cara-cara emosionalitas yang diajarkan oleh dosen-dosen saya itu sangat menyentuh hati.
Kenapa saya memilih UNES sebagai tempat untuk belajar? Karena UNES adalah universitas konservasi dan salah satu universitas yang melestarikan kebudayaan Indonesia.
Layaknya manusia, UNES terus tumbuh semakin dewasa. Peran dan kontribusinya semakin besar bagi Indonesia. Dengan belajar di sini, saya yakin akan semakin dewasa sehingga dapat berkontribusi bagi masyarakat dan bangsa, kini, esok, dan seterusnya.
Buat saya, UNES adalah salah satu perguruan tinggi yang luar biasa, terutama mampu mengangkat kota Semarang ini di kancah dunia nasional maupun internasional. Komitmen yang luar biasa dari UNES terutama untuk membuat kampusnya menjadi kampus konservasi dan bertaraf internasional. Kalau kita lihat di dalam kampusnya, komitmen itu benar-benar diterapkan. Begitu sejuk, begitu luar biasa penataan estetika kampus, sehingga mahasiswa pasti akan merasa betah, nyaman untuk bisa melakukan kuliah di kampus UNES.
Arum luhuring pawetan ing astoniro. Harum dan luhurnya lembaga ini tergantung pada tangan-tangan kita semuanya. Kami memberikan layanan terbaik dalam tridharma perguruan tinggi agar dapat menghasilkan insan akademik yang cerdas dan berkarakter konservasi. Kami terus melakukan inovasi agar UNES terus menjulang tinggi dengan semangat UNES mendunia untuk Indonesia.
Berwawasan konservasi.
Bereputasi internasional.
Rumah Ilmu Pengembang Peradaban.
Berdunia untuk Indonesia.
Saya memiliki keterikatan emosional yang sangat intensif kepada UNES itu. Pertama, intensitas belum emosional itu intensitas intelektual. Kuliah saya hanya di 2, tetapi intelektualitas yang disajikan IKIP waktu itu benar-benar baru saya sadari di hari-hari ini. Bahwa menjadi pintar saja tidak cukup, karena pintar itu teknis. Menjadi orang pintar itu harus sekaligus menyenangkan, itu pendidikan emosional. Nah, cara-cara emosionalitas yang diajarkan oleh dosen-dosen saya itu sangat menyentuh hati.
Kenapa saya memilih UNES sebagai tempat untuk belajar? Karena UNES adalah universitas konservasi dan salah satu universitas yang melestarikan kebudayaan Indonesia.
Layaknya manusia, UNES terus tumbuh semakin dewasa. Peran dan kontribusinya semakin besar bagi Indonesia. Dengan belajar di sini, saya yakin akan semakin dewasa sehingga dapat berkontribusi bagi masyarakat dan bangsa, kini, esok, dan seterusnya.
Buat saya, UNES adalah salah satu perguruan tinggi yang luar biasa, terutama mampu mengangkat kota Semarang ini di kancah dunia nasional maupun internasional. Komitmen yang luar biasa dari UNES terutama untuk membuat kampusnya menjadi kampus konservasi dan bertaraf internasional. Kalau kita lihat di dalam kampusnya, komitmen itu benar-benar diterapkan. Begitu sejuk, begitu luar biasa penataan estetika kampus, sehingga mahasiswa pasti akan merasa betah, nyaman untuk bisa melakukan kuliah di kampus UNES.
Arum luhuring pawetan ing astoniro. Harum dan luhurnya lembaga ini tergantung pada tangan-tangan kita semuanya. Kami memberikan layanan terbaik dalam tridharma perguruan tinggi agar dapat menghasilkan insan akademik yang cerdas dan berkarakter konservasi. Kami terus melakukan inovasi agar UNES terus menjulang tinggi dengan semangat UNES mendunia untuk Indonesia.
Berwawasan konservasi.
Bereputasi internasional.
Rumah Ilmu Pengembang Peradaban.
Berdunia untuk Indonesia.
Saya memiliki keterikatan emosional yang sangat intensif kepada UNES itu. Pertama, intensitas belum emosional itu intensitas intelektual. Kuliah saya hanya di 2, tetapi intelektualitas yang disajikan IKIP waktu itu benar-benar baru saya sadari di hari-hari ini. Bahwa menjadi pintar saja tidak cukup, karena pintar itu teknis. Menjadi orang pintar itu harus sekaligus menyenangkan, itu pendidikan emosional. Nah, cara-cara emosionalitas yang diajarkan oleh dosen-dosen saya itu sangat menyentuh hati.
Kenapa saya memilih UNES sebagai tempat untuk belajar? Karena UNES adalah universitas konservasi dan salah satu universitas yang melestarikan kebudayaan Indonesia.
Layaknya manusia, UNES terus tumbuh semakin dewasa. Peran dan kontribusinya semakin besar bagi Indonesia. Dengan belajar di sini, saya yakin akan semakin dewasa sehingga dapat berkontribusi bagi masyarakat dan bangsa, kini, esok, dan seterusnya.
Buat saya, UNES adalah salah satu perguruan tinggi yang luar biasa, terutama mampu mengangkat kota Semarang ini di kancah dunia nasional maupun internasional. Komitmen yang luar biasa dari UNES terutama untuk membuat kampusnya menjadi kampus konservasi dan bertaraf internasional. Kalau kita lihat di dalam kampusnya, komitmen itu benar-benar diterapkan. Begitu sejuk, begitu luar biasa penataan estetika kampus, sehingga mahasiswa pasti akan merasa betah, nyaman untuk bisa melakukan kuliah di kampus UNES.
Arum luhuring pawetan ing astoniro. Harum dan luhurnya lembaga ini tergantung pada tangan-tangan kita semuanya. Kami memberikan layanan terbaik dalam tridharma perguruan tinggi agar dapat menghasilkan insan akademik yang cerdas dan berkarakter konservasi. Kami terus melakukan inovasi agar UNES terus menjulang tinggi dengan semangat UNES mendunia untuk Indonesia.
Berwawasan konservasi.
Bereputasi internasional.
Rumah Ilmu Pengembang Peradaban.
Mendunia untuk Indonesia.
Okay. Good morning, ladies and gentlemen. May I have your attention, please? Our agenda is about to begin. We apologize for this delay because we were still waiting for some keynote speaker who have some trouble with the signal and the connection. I'd like to inform you on several information before we start our webinar. First, our webinar is online on Zoom for registered participants and live on YouTube in FIK UNES Semarang Official. Please kindly like and subscribe and inform your colleague to watch it in our YouTube channel. It is in FIK UNES Semarang Official. All the participants should turn off their microphone during the webinar and should turn on their video or webcam during the webinar. Question and answer are only available during the plenary and parallel session. Any questions should be written in the Zoom chat and will be delivered by the moderator. Our webinar has 300 participants in Zoom and over there 300 participants in our YouTube channel. Thank you. Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. The Honorable Minister of Finance, Republik Indonesia, in this occasion is represented by Mr. Febrio Kacaribu, PhD, the Head of Fiscal Policy Office, Ministry of Finance, acting as keynote speaker. We would like to welcome the Rector of Universitas Negeri Semarang, in this occasion represented by Acting Vice Rector for Planning and Partnership Affairs, Dr. Hendy Pratama. Special gratitude for the Dean of Sports Science Faculty, Universitas Negeri Semarang, Profesor Dr. Tandio Rahayu. The Honorable our keynote speakers, Profesor Haujan Yang, BS, MS, PhD, Chungsan Medical University, Profesor Dato Syed Muhammad Al-Junid, MD, MSc, PhD, Kuwait University. Welcome. The Honorable, our invited speaker, Professor Michael Chia, PhD, PPA, FMCCY. Associate Professor Syed Abdul Shabir, PhD. Assistant Professor Nirwan Tumbul, PhD. Profesor Dr. Oktiaworo Kasmini. Deans, Directors, and Head of Institution in Universitas Negeri Semarang, distinguished guests, participants, ladies and gentlemen. Welcome to a great occasion in which I am, Fatona Suraya, happy and privileged to be your master of ceremony. We are delighted to welcome you in the opening ceremony of webinar, the 5th International Seminar on Public Health and Education, Wednesday, 22nd of July, 2020. Under the theme, Strengthening Disease Prevention through Health Education and Physical Activity for Sustainable and Equitable Health Development. For your information, our webinar is also live on YouTube in FIK UNES Semarang official channel. Please kindly like and subscribe. Ladies and gentlemen, the first agendum is National Anthem of Indonesia Raya. We would like to invite you to stand, please. Thank you, and kindly be seated. Move on to the next agendum is prayer. Let us say our prayer. Amen. Ladies and gentlemen, the next agendum is speeches. The first speech is from the Dean of Sports Science Faculty, Universitas Negeri Semarang. Please welcome to the one and the only, Profesor Dr. Tandio Rahayu.
Thank you, Ms. Raya. Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. Let us pray and thanks unto the Almighty, who has been giving us lots of mercies and blessings. So until today, we can stay in a good health in this difficult pandemic situation. Further, I would like to welcome the distinguished speakers who have been willing to spend their precious time to enlighten us virtually in this seminar. Your Excellency, Minister of Finance of Republic Indonesia, in this occasion represented by Mr. Febrio Kacaribu, PhD, the Head of Fiscal Policy Office, Ministry of Finance. Professor Hao Jianyang from Chung San Medical University, Taiwan. Professor Syed Mohammed Al-Junaid from Kuwait University, Kuwait, Professor Michael Yongwatja from National Institute Education, Singapore, Associate Professor Syed Abdul Sabir from Taipei Medical University, Taiwan, Associate Professor Niruan Tunbul from Mahasarakam University, Thailand, and Professor Oktia Woro from Universitas Negeri Semarang, Indonesia. Furthermore, I also would like to welcome the Honorable Rector of Universitas Negeri Semarang, in this occasion represented by Acting Vice Rector for Planning and Partnership, Dr. Hendy Pratama, MA, Deans, Director, and all head institution in Universitas Negeri Semarang, the guests of honor, and all of the conference participants. Ladies and gentlemen, this event, the 5th International Seminar on Public Health and Education, is a collaboration event among Faculty of Sports Science UNES, Health Education National Networking Indonesia, Indonesian Public Health Association, and some prominent of Indonesia universities in health education and physical activity. This seminar brings together academic expert practitioners from Southeast Asia and beyond to share the new knowledge, ideas, and experiences pertaining to public health, health education, physical activity, medicine, and sustainable health development. Today, this event attended by approximately 300 registered participants, including 135 presenters from 8 countries. Besides, in this Zoom meeting room, this event could also be followed in YouTube live streaming. Finally, thank you for your participation, and in particular, I would like to give a high appreciation to the organizing committee, led by Assistant Professor Sri Ratna Rahayu PhD and all the staff. Your hard work make this event valuable to all parties. And please kindly accept my deep apologies for any imperfection and any inconvenience during this event. Thank you very much for your kind attention. Wassalamualaikum warahmatullahi wabarakatuh. Back to you, Ms. Raya.
Thank you. Thank you, Professor Tandio Rahayu, for the speech. Ladies and gentlemen, it is now an honor for us to invite the Rector of Universitas Negeri Semarang to give us the welcoming speech and to officially open our webinar. In this occasion, is represented by Acting Vice Rector for Planning and Partnership Affairs, the Honorable Dr. Hendy Pratama, MA. The screen is yours.
Can you hear me? Okay.
Yes.
Okay, thank you. Assalamualaikum warahmatullahi wabarakatuh. And good morning, ladies and gentlemen. I hope that my slide is already on now.
Yes, it is.
Okay, thank you very much. Ladies and gentlemen, my name is Hendy Pratama. I'm the Vice Rector for Planning and Partnership. And today I'm representing Professor Dr. Fatur Rahman, the Rector of Universitas Negeri Semarang, because he has another agenda today. He is very sorry and apologize for the guests and also speakers. and let me represent his speech for you today. Ladies and gentlemen, welcome to the 5th International Seminar on Physical Health and Education. And this is the 5th. It means that it has been done many times before, very successful, as long as I remember, as part of the consortium and also part of the hard work from the Dean, Professor Tandio. Really thank you about that. And today we would like to welcome Mr. Febrio Kacaribu. And Mr. Febrio Kacaribu is one of the young figures in Indonesia who's got a very talent, and also achievements have been admitted and also recognized by public. Mr. Febrio, welcome. And also Mr. Amir Hidayat was my friend in Australia when we were studying in Australia. Mr. Amir Hidayat is the head of the macroeconomics analysis. I think he's your subordinate. Send my best regard to him. And welcome to UNES, Mr. Febrio. We'd like to welcome Prof. Haujan Yang, Professor Syed Mohammed Al-Junid, Professor Michael Yong Ha Chia, Associate Professor Syed Abdul Shabir, Associate Professor Nirwan Turbul from Thailand. And also, I would like to welcome, it is actually very familiar for me to see Professor Oktia Woro. And all of those speakers are very remarkable speakers in their areas, and we would like to hear them today and see and also witness their ideas. And I think their ideas would be breaking through in our field, ladies and gentlemen. Now, this is a very unfortunate that we have to hold this event, International Seminar on Public Health and Education 2020, because I've heard that this event should be very big, supposed to be administered in a big hall with dances and also performances. And I think it would be, that's how we planned it to be. But of course, because COVID-19, just like any other public events, we have to adjust. And I don't think it is a problem because ideas can be exchanged everywhere. I think we can also see how brilliant the ideas without having meeting face-to-face. However, I think next year, there would be a big chance for us in 2021 that the International Seminar on Public Health and Education shall be delivered offline. And I hope that all the speakers today coming here online would come to us again next year. Ladies and gentlemen, we would like to introduce you to our vision. Our university, we would like to become a conservation-oriented university with international recognition. And this is our milestone. In the end of the day, in 2024, we would like to have a science techno park. And as a teaching university, we would like to be an international teaching institute. This is the 5 priority programs from the rector. Our rector, Professor Dr. Fatur Rahman, has set those 5 preference programs. The first one is the excellent human resources. That's including the staff members and also the faculties and also the students. International Teaching Institute, that's how we would like to treat ourselves because we are rooted from the Teaching Institute. We would like to focus on the international accreditation and certification. And that's very important nowadays. Innovation, publication, and also investment in the future, and also good governance and excellent service. Ladies and gentlemen, we are very proud that we are accredited A nationally, because this is not an easy feat. I think only 60 universities, around 4,000 universities in Indonesia that's got the A accredited. So I think this is a good thing for us to have this, and we need to maintain this, because the ministry said that if in any chance that our education quality is going down or tarnished by something negative, that this accreditation could be downgraded. and we don't want that. We have to maintain, ladies and gentlemen. We already got 4 study program certified internationally by Asian University Network, or AUN-QA. And we have Indonesian Education Department, Biology Department, Physical Education, and Economics Development programs that have been certified. This year, we would like to have more. I hope that it is not affected by COVID-19. I think we have online visitation when we would like to have more study programs to be internationally certified. Ladies and gentlemen, now this is the uni rank for ICU, that the rank that put us into 606 in the world, and also number 22 in ASEAN, and also number 10 nationally, and we are proud of this. And in Indonesia, we are now number 5 in the number of the applicants nationally. And I think this is also a proof that the attention of the public to Universitas Negeri Semarang, or UNES, has been increasing years by years. There's a thanks to the leadership of the Professor Dr. Fatur Rahman, and today we would like to see this trend to continue. Thing is that our publication, I think 10 years ago, we start with around 50 titles on Scopus. Nowadays, we have 1,606 per year, ladies and gentlemen, meaning that it is I think this is accumulatively 1,606, which is very good, I think. Since 10 years ago, I think we almost started with 0 title. Now, and this is our international networking. We work with some countries in Asia, and also Australia, United States, and also Europe. And I think we would like to continue this. And this conference is one of the application and implementation of this kind of a partnership. Ladies and gentlemen, today's agenda is very important because we would like to see some answers, ideas, insights about how we would like to have a better community, a healthier community, not only in Indonesia, but in the world. These facts, I took it from the website of WHO, the World Health Organization, that 82% of the premature death caused by cardiovascular diseases, actually 82% are in low and middle income countries. I think here in Indonesia, we are in the middle income countries, meaning that 82% chance for our people to get more and more people have the cardiovascular diseases. I think the only way to prevent cardiovascular diseases as the #1 cause of death globally is that we would like to see the control of the tobacco use, unhealthy diet, obesity, physical inactivity, and harmful use of alcohol or any other dangerous diet. Meaning here that we have to promote the physical activities. We have to promote healthy diet. We have to try to hinder the use of tobacco. This is kind of the action that we have to take together, ladies and gentlemen. Now, I think because Mr. Fabrio is here from the Fiscal Policy Office, I think you also have some understanding and also some instruction for us on how to have a better universal health care. And today we have universal health care called BPJS. Although it's not perfect, it's very helping for the people who need that. I personally use that universal health care. And there is also some good points. That is, we have a low healthcare cost for the economy, not as expensive in the United States, for example. And also, we would like to force hospitals and doctors to provide same standard of low, although the cost is quite low. And we would like to eliminate the administrative cost by eliminating the need with the private insurance. However, with the availability of BPJS, there are some misuse for some healthy people, for example, not really sick people going to the hospital, and some healthy people, they have still to have to pay for others' medical care. That's one problem. I don't mind with that, but some people think that's a problem. And without financial incentive, people usually they abuse the use of BPJS. I think that sometimes people go to hospital and doctors without any symptoms whatsoever. And then we also think that a universal health system has the long wait times for the elective procedures, meaning that some procedures, if that's too expensive, sometimes it takes longer because the decision is very hard to make. Then sometimes the result is very fast. So, ladies and gentlemen, those are the issues of today's talk. Not really limited to that, but I think we would like to hear more and more ideas about this. And ladies and gentlemen, today, this is the time for me, representing the Rector of Universitas Negeri Semarang, Professor Dr. Fatur Rahman, to open this event and have a good conference, and may you enjoy everything, including enjoy the ideas and also the friendship that you find here. Thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Dr. Hendy Pratama, MA, for the very informative and comprehensive speech. Ladies and gentlemen, this is the end of the opening ceremony. As the proverb says, the sooner the better. Without further ado, we are going to reach to the main agendum, which is keynote speech. For your information, this keynote speech will have no question and answer session. All right, ladies and gentlemen, I'd like to introduce you to the first speaker of the day. He was born in Sidikalang, North Sumatra, on February 27, 1978. He obtained his Bachelor of Economics in 2002 from the University of Indonesia and his Master in International Economics and Development from the National University of Australia in 2005. In 2014, he finished his PhD from the University of Kansas. He has been the head of the macroeconomic and financial research of the Center for Economic and Community Research, LPEM, since 2015 and acted as the head of the Fiscal Policy Office on April 3, 2020. His areas of expertise include business economics and projection, economic models, financial economics, monetary economics, and public policy analysis. He will deliver a topic on opportunity and challenges of health investment from disease prevention aspect for economic development in Indonesia. Let's welcome Mr. Febrio Kacaribu, PhD. The screen is yours.
Good morning, University Negeri Semarang. It is such a privilege to be here. I'm so honored that I can be here with everybody. I would like to convey Bu Sri Mulyani's regret that she could not be here with us to deliver the keynote speech for this outstanding and exceptional event that is hopefully still going to be very fruitful and very useful for many of us and for all of us who are listening from everywhere we are. Ladies and gentlemen, I would like to deliver some remarks in regard to opportunities and challenges of health investment from disease prevention aspect for economic development in Indonesia. Clearly, ladies and gentlemen, this is going to be my speech is going to be colored a lot by our assessment as to the current condition globally and also in Indonesia more specifically. So if I may, I would like to tell everybody about what is going on with our health crisis in Indonesia and also globally, and how the government has been trying to handle these challenges, and how everybody in the world basically also trying to navigate around this very unprecedented situation maybe only presented itself once in 100 years. So I would like to divide my speech into four sections. First, I'll be talking about COVID-19 economic impact and our responses. And we'll talk about strategic value of health. And then we'll talk about health investment, opportunities and challenges. And later at the end, I'll deliver some takeaway messages. Ladies and gentlemen, logically, we would like to think about this current condition started from the health crisis. Health crisis came from the COVID-19 pandemic situation where we are globally, everybody in the world is facing this problem. And everything started back in early 2020. And it spread it very fast, very quickly. Everybody in the world becoming at risk, and a lot of us now becoming infected. In the absence of vaccine, it is going to be high uncertainty, even though we are trying the best. Everybody in the world, all countries in the world, trying their best to come up with good economic policies. But in the absence of vaccines, it is going to be with very high uncertainty. So this is the situation everywhere in the world. Ladies and gentlemen, I don't think you guys are foreign to this data. Right now, Latin America countries are among the worst hit by this virus. Indonesia is not really far from bad. We are still struggling as well. We introduced a strict social distancing protocol studied in Jakarta, and now it is spread to many other areas in Indonesia. The epicentrum was studied in Jakarta, but now arguably Jakarta is slightly more manageable. But of course, this will all depend on the discipline of everybody. The people will need to keep social distancing and wear their mask, wash their hands, and stay at home if possible. That is of course very challenging because the nature of our population, especially our workers, majority are in informal sectors. So not many of us actually have the privilege to be able to work from home. For us, like the middle class and also people who work at the universities, we do have the luxury of staying at home and then work from home, study from home, etc. But for majority of Indonesian and maybe majority of people in the world, that is not really such a luxury that they can actually have. So this is a very risky still situation. But if you look at what happened to the economy, global economy is at the brink of a recession in 2020. In fact, World Bank is actually estimated that close to 92% of the countries in the world will be in recession this year. Indonesia is trying to be not in that 92% group. That is going to be a very, very hard undertaking. But our data shows that there is a possibility that Indonesia will not go into a recession. But ladies and gentlemen, that is not something to boast, to be honest, in this current situation, because Indonesian economy is usually growing at 5% per year. So even if we manage to grow at 0% this year, that is going to be already a very deep correction from our usual economic growth. What it means is we will have a lot of extra number of unemployed workers, and we will have extra number of people who are going into poverty. That is not really a pretty picture. Even though in many parts of the world, the situation is going to be much worse than this, but it is not a good picture. So we are struggling and we strive in the government, and also we would like to invite everybody to join in this effort to try to do our best that this year we would like not to have a recession. We would like to limit the number of unemployment, the number of additional poverty, because this is going to be affecting directly the livelihood of everybody, the health situation of everybody. Not to mention, we are trying to still alleviate the problem of undernutrition and also stunting problem in our country. So this is going to be putting those causes in the big challenges because of the shock and the crisis in 2020. So we are trying our best in 2020 and see if we can bounce back as fast as we can, especially in 2021. Ladies and gentlemen, okay, next slide, please. If we talk about policy responses dealing with COVID-19 crisis, this is also showing that the government mind is actually put in the right place, that we are looking at this crisis as a health crisis first. We put forward health measures. We quickly appointed dedicated hospitals, emergency hospitals, built infrastructures needed. Testing and tracing, we do strategically, although some might argue that we need to do a lot more of that. We introduced physical distancing, work from home, study from home, and also large-scale social restriction. In Jakarta, we call it PSBB, and in some other cities also this PSBB is starting to be introduced as well. As a result, logically, with this social distancing, there is a sudden stop of our economic activity, especially, again, I explained to you that majority of our economic activity is actually in the informal sector. Majority of our workers are in the informal sector. So when there is a social distancing, large-scale social restrictions like the one introduced 2 months ago in Jakarta, it caused a lot of economic activities. As a result, social safety net is going to be paramount. A government came up with non-cash food programs, and also we expand our social spending. We introduced 100% discount on electricity bills for those who belong to the poorest group of the society. We also expand our existing social spending program. And that is going to be hopefully to help our poorest group of the society to survive the 2020 potentially crisis situation. But if we look at it, it is also going to affect our business sectors, especially if we think about it logically, who are the most prone to the risk of the crisis. Again, it is going to be the informal sector. If we go to the business sector, we are going to look at small, medium enterprises and micro enterprises as well, because these are the groups that are very prone to this crisis. So we introduced a lot of programs for this group. We introduced interest subsidy for the micro and small, medium enterprises. We introduced tax incentives. We introduced overall, we call it National Economic Recovery Program. Ladies and gentlemen, we are not alone in this. Everywhere in the world, government, economies trying to strive with similar approaches. They introduce health measures, social safety net, and also the business support. Go to the next slide, please. Fortunately for Indonesia, we have a very collaborative stakeholders during this pandemic, including and most importantly, is the parliament. The parliament is now, at least in 2020, giving a lot of leeway for the government to adjust its budget throughout the year. because normally our government, our fiscal policy is very, very disciplined. In years now, we have managed to keep our budget deficit always below 3%. In some years, it was even below 2%. And arguably, that discipline is going to pay off during this crisis time, because now we are among the countries that are posed to be resilient, and we have room fiscally to intervene the economy, and also giving support for the economy to bounce back. So this is a result of a fiscal discipline that we have introduced since years ago. And under the leadership of Minister of Sri Mulyani, this fiscal discipline is usually always the most important one that we talk about every day. But in 2020, we are given the allowance to widen the deficit. The last one that we put forward is 6.34%. That is very, very big compared to what we have done before. But again, this is an extraordinary situation. We need extraordinary measures. The law is also allowing the government to introduce this budget deficit beyond 3% usual limit up to 2022. So in 3 years, the government will be given some flexibility in terms of managing its deficit. So hopefully, go to the next slide, please. So hopefully this will giving flexibility to the government, but also giving enough cushion for the economy to be given support by government spending. So this is the evolution of our budget this year. Initially, in January, we came up with a budget of 2,540 trillion rupiah. And then we changed that back in early April to 2,613. And then lastly, we changed that about a month ago to 2,739 trillion rupiah. And the budget deficit, initially, it was minus 1.76% of GDP. It was changed to 5.07% of GDP. And now the last budget that we put forward is giving us 6.34% of our GDP. Ladies and gentlemen, this is not an usual situation. This is a very extraordinary situation. So are we doing this without risk? Not necessarily. We are doing this with a lot of risk that is going to be needing a lot of attention, careful attention from the government, from NGOs, how to manage our deficit for the next 2-3 years, and how to manage increased risk of our debt to GDP ratio. Again, our discipline in years have been keeping the GDP net debt to GDP ratio at around 30% last time. As a result of this deficit in 2020, we are looking at our debt to GDP ratio to increase significantly from that 30% of GDP to 36% of GDP in 1 year. And that will stay for the next several years. But again, fortunately, comparably to many other countries whose debt to GDP ratio among the emerging economies like Malaysia, Thailand, and so on and so forth, whose debt to GDP ratio are usually around 50% or up, this is giving us a lot of flexibility in terms of managing the risks from the debt as well. Moving on to the next slide, this is what we put forward as our National Economic Recovery Program. A lot of programs, and of course, we logically will start from health. So the big chunk of this budget is going to health, or the first one is for handling the COVID-19 patients, and also for paramedics. We also providing compensation for death. We also providing support for health insurance fees, and we also provide for the task force and tax incentive for health equipments, and so on. And a lot of these, it's probably not going to be enough time for me to explain everything, but these are a big chunk of National Economic Recovery Program that the government for the next 5 months will try the best in trying to spend the money. This is going to be, it might sound trivial, but this is a big challenge for an emerging economies government like Indonesia, that we could actually spend the money wisely, quickly, but also without moral hazard, without any leakages. So this is a very challenging situation that we're facing at the moment. The government is facing big challenges. Everybody is facing big challenges, even people to the poorest group of society. We move on to the next one. Yeah, I'm gonna skip this one. Next one. So this is the a little bit of detail of that health budget, 87.55 trillion rupiah. 75 trillion was the initial stimulus expenditure. It was then expanded to 87.55. If you look at the details, you can see what the money is actually for. And arguably, some of these are, some of you in Indonesia follow the news that our government struggled in trying to spend this money. That is a fair analysis, a fair assessment to make, and the government is making best effort to try to simplify the process to make sure that the money can go directly as fast as possible to the beneficiaries of this budget. Next, this is the brief picture of our 60% poorest of the population. And as you can see from this picture, the 40% poorest of the society is given majority of the help. This is from the 203.9 trillion rupiah. See that majority of the money is spent on the 30% or 40% poorest of the population. But then we also expanded to some middle class groups. For example, in Jakarta metropolitan area, we introduced cash transfer. In some cities outside Jakarta metropolitan area, like Semarang, we also introduced some basic food social assistance. In the village area, we also reallocate some of the BLT, which is village fund cash transfer, to be converted into food voucher program as well, and so on and so forth. We also introduced recently in 2020 the unemployment benefit scheme, which is still new and still having a lot of challenges, to be honest, but we are trying to fix along the way. Now let's move on to the health issue, more general. Even though 2020 is posing us with big challenges, ladies and gentlemen, we would like to still keep our eyes long ahead to look at what is going to be needed for the reform of the health sector in Indonesia. These are the strategic values that we adopt. We would like to have high quality health because we believe that will boost productivity and a good quality of life. Lower quality of health, clearly that's going to be lower productivity, and also because I'm from fiscal office, that is going to be more burden on health cost for the government budget. But if we push for better productivity, that will push for better economic growth, and higher economic growth that will also help the sound fiscal and improved tax revenue. And sound fiscal, now we will have a much wider, much bigger space for health sector spending as well. So these are the logical ways we're looking at it for the long term to medium to long term. What we're doing currently, next slide please, government is doing from 3 different ways in terms of revenue, i.e. we give tax incentives, we give tax allowances, tax holidays, tax exemption for especially for health devices and pharmaceutical. Ladies and gentlemen, this health sector in Indonesia, especially the medicine sector in Indonesia, is very, very underdeveloped. We have very good, very globally competitive pharmaceutical companies, but we import majority, close to 90% of the materials are imported. So we need to build our pharmaceutical industry a lot better than what we have right now. In terms of spending, central government expenditure, we go through Ministry of Health, National Food and Drug Agency. We also have close to 30 to 40% of our budget goes to regional, and we do community health care centers, puskesmas, and we support regional incentive fund, for example, for stunting intervention. In terms of financing, this is just started, not something that we can be proud of yet, to be honest. We would like to open as much as possible room for a private sector to join and build and operate in health industries, building hospitals, building teaching hospitals, building more of pharmaceutical factories, building more of a lot of resources that we need for our health sector. So we would like to open this, and if some of you are investors, please look at Indonesia. And this is a big country with vibrant middle class growing. 2020 clearly is going to give us a big challenge, but 2021 is giving us more optimism that we can recover from this crisis quite quickly. Next slide, please. This is how we have spent our money as a nation. See that the introduction of national health insurance back in 2014, that increased the share of insurance. Used to be below, and now we're looking at, let me see, central government, local government. So the big chunk of the national health insurance is now paying the health spending in Indonesia. But interesting, look at that out of pocket, that's OOP of the people, still very big. And the role of private health insurance, that is the red one, that is very not good. We would like to open more of those opportunities for private health insurance because we can't rely on government budget only. Next, this is how we see ourselves comparably to some other countries in the region. We are among the lowest in terms of health spending total in the country. Indonesia just entered the upper middle income group based on the World Bank classification based on 2019 data. Among this upper middle income group, the health spending is actually 5.8% of GDP. So we are now at 3% of GDP, is really far from our peer group comparison. So this is clearly showing that we need to do a lot more in building our health sector industry in this country. Next. If you look at a little bit long run comparison, there's a good news here that in the last 17 years, for example, there's been big changes in how we look at the diseases in our country. Changes in morbidity in the last 17 years shift now into a behavior related. In a way, this is a good news. But in another way, this is also a bad news because now we have a higher income per capita and our diseases are now related to behavior. So dietary risk, high systolic blood pressure, high fasting plasma glucose, tobacco, child and maternal malnutrition, still a problem for us, although no longer number one, but still a big problem for us. So this is something very interesting for everybody in the health sector to look at. And NCDs are estimated account for about 70% of death in Indonesia now, because this is now 2020. That was data from 2017. So everybody, this is the challenge that we are all in this, looking at it, how to alleviate this problem from our country. Next slide, please. And this is how the government has been trying to intervene through that national health insurance, but still without perfect situation, clearly, because as you can see, our national health insurance needs to be reformed as well. We don't want our system to be always in deficit and expecting government injection every single year and increasingly bigger number. Next. How do we look at investment opportunities in Indonesian healthcare? We are moving from a very low base. So there are a lot of opportunities for companies, for private sectors, for global companies, for domestic companies to start looking at opportunities here. The government is very serious about putting forward a lot more investment in health sectors. Clearly, the pandemic 2020 is a wake-up call. Clearly, we realize that our healthcare system is not ready for a pandemic of this scale. We would like to be in a better position next time risk like this came forward. We would like to be in much better position in terms of infrastructure, in terms of our human resources, in terms of achievement in alleviating some of the basic problems like stunting prevalence in Indonesia. How would fiscal support for the healthcare reform? We try to start, next slide please, for 2021's budget. We would like to accelerate recovery from COVID-19 pandemic. We would like to keep our excellent generation program, strengthening promotive and preventive program, promoting healthy living community movement, and also still ever decreasing stunting and increasing immunization coverage as well. Central and regional government will need to coordinate much better because 30 to 40% of our budget is actually transferred to the regional government. We would like to have a better synergy in planning and budgeting, financing of support of the supply side, strengthening for promotive and defensive programs as well. Health security preparedness, clearly we need to upgrade a lot more on this, strengthening the health emergency framework, prevention, detection, and fast response integrated health system. JKN, the National Health Insurance System, is needed to be reformed, strengthening the quality of health services by maintaining the financial sustainability. We can't have this healthcare system without a sustainable financial system supporting it. So we will need to do some adjustments, and this need to be done very carefully. Next, challenges ahead. Clearly, we have aging population. Nowadays, we still have young population, but not long from today, well, we will lose this demographic bonus. We will start aging population sometime in 25 years from now. So when we are still young, we would like to be healthy and more productive and produce a lot more productivity. Hence, when we enter the aging population period, like it is in Japan, in many other advanced countries, we would like to be better positioned in terms of healthcare facilities, healthcare infrastructure, and also healthcare human resources. We would like to start the reform now, today, not later, because we would like to be able to better position ourselves when these challenges appear in a much better scale. Now we are facing the challenges already. So for that, we need to invest a lot in healthcare industries. Next slide, please. We would like to also mainstreaming health into national development in the line of ministries, improving education on healthy life, improving the quality of environment, early detection of diseases, and increasing physical activity starting from younger ages. This season of COVID-19 pandemic is the best time to promote healthy lifestyle, and at the same time, we would like to open and create opportunity for more investment in healthcare industries. Last takeaway messages from us. Let's take important lessons from 2020. That this tiny virus unseen is leading us to huge impact on global scale and global economy, including Indonesia. We need to strengthen our resilience in all levels, country, region, and individual, and even globally. Government need to keep on improving the quality of health investment. We would like to open this, and we would like to see a lot more investment in healthcare, in health product, in health industries in general. We would like to strengthening promotive and preventive health program in Indonesia. COVID-19 pandemic is a problem, is a big challenge, is a big risk, but it is also an opportunity. We should use this as a momentum to accelerate our health sector reform, build health, not only healthcare, preventive matters, and we will need to take advantage of the existing IT reform to be used in the health sector as well. AI, robotic, telemedicine, and online workout class. These are all very important nowadays, especially we realize when we can do everything from home. So, ladies and gentlemen, thank you very much for listening. Again, I would like to convey regret from Minister of Finance, Sri Mulyani. I would like to congratulate you on this big event, and happy seminar, happy conferencing, happy discussing. May the strive that we do every day will bear some fruits for our self and also for our children in the future. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you, Mr. Febrio Kacaribu, PhD, for the very comprehensive and informative talk. It's truly opened our mind on the current issue on economic challenge due to the COVID-19 outbreak, meaning that the society health condition is very crucial for the economic growth. Thanks a lot, Mr. Febrio, and please send our best regard for Ibu Minister of Finance, Ibu Sri Mulyani. Thank you. Ladies and gentlemen, now we reach to the next keynote speech under the topic, the role of health education in improving quality of life. The speaker is a professor of Department of Public Health, Chungshan Medical University, Taiwan, acting as the director of Center for Faculty Development, Chungshan Medical University since 2014. His research interest is in the area of mental health, public health, and epidemiology. He has tremendous publication, to name but a few: Hepatitis A virus vaccination program, 2020, Taiwan HIV study group, 2020, attention deficit hyperactivity disorder, ADHD studies, 2019, and tuberculosis control program in mountain area, 2019. Without further delay, let's welcome Professor Hao Jan Yang.
Thanks very much for Raya's introduction, everyone. I'm so glad to be here, sharing with you one of my latest research entitled "Factors of Preventing Migrant Workers in Taiwan from Mosquito-Borne Diseases." In this study, we implement a brief health education program by applying the health belief model to fit the theme of this session about the role of health education in improving quality of life. And I am Hao Jan Yang from Taiwan. Next slide, please. Speaking of Taiwan, I live in Taiwan, and It's a small island located at the southeastern side of China. It's a developing society, but we have the second lowest birth rate all over the world. Getting fewer and fewer manpower makes importing workers from other regions is necessary. Next slide, please. Currently, there is a total number of more than 700,000 migrant workers in Taiwan. And this accounts for about 3% of Taiwan's population. We have 23 million people living in Taiwan. And the workers are mainly from Southeast Asian countries, with Indonesia the most, and Vietnam the second, and the Philippines the third. In this study, we only recruit Filipino workers for the language stack because we can communicate with each other in English. Okay, next slide, please. Filipino migrant workers in Taiwan mainly engaged in the type of manufacturing of occupation. It accounts around 80% of the workers. And the second most type is healthcare type. Next slide, please. The health education program in this study is important because mosquito-borne diseases are prevalent in Southeastern Asia countries. These diseases include malaria, dengue fever, and chikungunya and yellow fever. For example, there were about 27,000 people died of malaria in Southeast Asia in 2016. Next slide, please. In Taiwan, foreign workers accounted for a proportion of imported cases in the past 15 years. For malaria, the percentage is around 16%. And for dengue fever, it can be reached to around 29%. Next slide, please. The figure showed in here, the figure here shows that both dengue fever cases and the deaths dramatically increased in the past decade in Southeast Asia. You can see in the dark part of the figure. But in Western Pacific region, they were relatively stable. You can see the light part of the figure. So next slide, please. The Philippines has accumulated 40,000 cases by the end of February 2019. And in 2018, there were 350 cases of dengue fever, imported cases in Taiwan, and 61 of them entered from the Philippines. Next slide, please. For malaria, the number of cases in the Philippines in 2018 was approximately 4,000. Although Taiwan was officially issued with the WHO certificate of registration for malaria elimination, still there is an average amount of 10 to 30 imported cases have been reported each year in Taiwan. Next slide. So, how do we prevent from mosquito biting? In general, we have physical prevention fashions, such as use screens on doors and windows. We also have chemical prevention fashion, such as use mosquito coil. These are a part of the health education program that we deliver to foreign workers in this study. Next slide. In this study, we introduced the health belief model as conceptual framework, which consists of 5 concepts in terms of perceived susceptibility, perceived seriousness, perceived benefits, perceived barriers, and the cue to action. Next slide. Many previous studies have shown that this model worked in preventing mosquito-borne diseases, as you can see in the slide. Next slide. So the aims of this study were to design an intervention program for preventing mosquito-borne diseases among Filipino workers in Taiwan. And the second aim was to explore the connections of foreign workers' knowledge, health beliefs, and the behaviors about mosquito-borne diseases with the outcomes of health education intervention. And the third aim was to clarify which domains of health belief model were effectively improved after implementing the intervention program. So we hypothesized that knowledge of mosquito-borne diseases have a significant impact on preventive practice. And the health beliefs of mosquito-borne diseases have a significant impact on preventive practices. And then health education interventions can significantly affect knowledge, health beliefs, and preventive practices. The participants of this study were Filipino workers from 2 Catholic churches in Taichung City of Taiwan. The inclusion criteria was 20 years old or above who gave informed consent. And the exclusion criteria was not completing the research. There were 291 workers included in the subsequent analysis. And the material used in this study were English version of questionnaires for pre-test and for post-test, and the English version of educational flyers based on information from WHO and the Taiwan CDC. Next slide. The study questionnaire comprised the concept of knowledge and the 4 domains of health belief model, as well as preventive practices. They all had fair to satisfactory internal consistency with the Cronbach's alpha range from 0.65 to 0.90. Next slide, please. And the process of this intervention started from explaining the research purpose and the processes by 2 of our research assistants. And then they did the pre-test and then went for the health education and then did the post-test. The process took about 30 minutes after our participants finished doing mass in church on Sunday. Next slide, please. The study period was from May to September of 2018, and we used SPSS and the AMO software for analysis. Next slide, please. The demographic characteristic of the participants showed a more female and a younger feature. And we can see that more than half of the workers came to Taiwan for the first time. And about 60% of them can listen and speak Chinese. Next slide, please. The information of mosquito-borne diseases was mainly from television and from doctors or nurses. 6.2% of the participants and 13.1% of their families had ever suffered from mosquito-borne diseases in the table. Next slide. The bivariate analysis showed that female participants had a significantly higher preventive practice than male. Next slide. Next slide, please. Please go to the next slide. Thank you. Next slide, please. Okay, I'll go on. And we can see on the next slide that the older age, the higher knowledge and the preventive practice scores. In particular, there was a significant trend for preventive practice. Next slide.
Prof. Hao-Jan, Prof. Yang, we apologize, there is a delay in the computer. Please wait a second.
Okay.
Yeah, we apologize for that.
That will be fine. Please go to slide 22. Slide number 22, right. Thank you. Next slide. And next slide. Okay, thank you. Next slide, next slide. Thank you. Participants with a higher educational level showed a lower perceived barrier score and a higher preventive practice scores. And those who engaged in manufacturing occupation perceived the least barriers when comparing to those engaged in other types of occupation. Next slide, please. As we can see that if Filipino workers showed better Chinese proficiency, they report less perceived barriers. Okay, next slide. As for monthly income, more income was associated with less perceived barriers. Next slide. When performing path analysis, controlling for other variables, preventive practices was positively affected by knowledge and the perceived seriousness, and negatively affected by perceived barriers. Next slide. So, which domain changed before and after implementing the health education program? We can see that the knowledge and the perceived seriousness and the perceived benefits and the preventive practices were all improved after implementing the health education program. Yet the perceived barriers slightly but significantly declined in this table. Next slide. Our final results from structural equational modeling showed that after taking health belief model domains into account, knowledge and the perceived seriousness and the preventive practice significantly improved in the analysis. So we have several summaries in this study. Please go to the next slide. In this summary, we found that findings showed that knowledge, health barriers, and preventive behaviors about mosquito-borne diseases can be affected by demographic variables. As you can see, the age is associated with knowledge, and health and educational attainment, duration of stay in Taiwan, and the Chinese proficiency, and the average monthly income was negatively associated with perceived barriers. And the gender and the educational level and the duration of stay in Taiwan were associated with preventive practices. Next slide. Findings from this study fully support our hypothesis 1, showing that knowledge was positively associated with preventive practices. Next. And as for the hypothesis 2, we found that perceived seriousness were positively associated with preventive practices, and the perceived barrier were negatively associated with preventive practices. This will partly support the hypothesis 2 of the present study. Next slide. Through the intervention, the positive impact on the knowledge, perceived seriousness, and the perceived benefits, and the perceived barriers, and the preventive behavior partly support our hypothesis 3. Next. In conclusion, we have several lessons learned from this study. First, to prevent the threatening from mosquito-borne diseases, a brief health education program based on health belief model can work. A good quality of life should be based on not suffering from diseases. To reach this goal, developing multi-language educational flyer for foreign workers is necessary. And it is important to reach out foreign workers from where they get together. And such program can improve health and the quality of life, not only for foreign workers themselves, but for their families in the homeland as well. This is the talk of the day. Thanks for your time and attention. Thank you.
Thank you very much, Prof. Hawan Yang. It's very interesting to learn about the health belief model in your research for the immigrants in Taiwan. And it is very enlightening to know the impact of knowledge, belief, and education intervention for preventive practice to improve the quality of health. It's really new for me. Thanks again for the enlightening speech, and we are truly looking forward for more collaboration with you and your university, especially in terms of research and publication.
Very welcome.
Thanks again.
Thank you.
Ladies and gentlemen, move on to the last keynote speech on strengthening healthcare system of developing countries through research and development in health economic and financing. The speaker is the first professor of health economic in Malaysia. His main interest is in the strengthening of healthcare system of developing countries through research and development in health policy, health economic, and financing. He has conducted more than 50 research projects. Most of them are to support policy decision on health economic and financing. He currently involved in supporting a number of developing countries to implement social health insurance program. His work on social health insurance covers many countries around the world. He is now acting as chair of health policy and management and director of postgraduate program, Department of Health Policy and Management, Faculty of Public Health, Kuwait University. Let's welcome Professor Dato Syed Muhammad Al-Junaid, MD, MSc, PhD.
Thank you, Soraya. Thank you so much for inviting me to participate in this interesting international conference on health education and public health. I'm happy to share some of my views on the roles of research and development, which I think all of us are in the academic institution and also, of course, in ministries of health and other health sectors are interested in, especially during the current situation where we are having the COVID-19 pandemic. Let me share you my desktop. Can you see the desktop, my slides now?
Yes.
Thank you so much. Yeah. These are the things that I will try to cover within these 30-minute periods. I will talk about the current challenges in healthcare system, and I will touch a bit the issues on COVID-19 pandemic, which have a lot of link to research and development. The need for us to strengthen our health system, and then I will talk about the sources of health financing, which relates closely to, of course, health economics and financing, and then what are the barriers that we are facing now in conducting research and development in health economics. So these are the four major challenges, or five major challenges that we are facing in the health system globally. As mentioned by the first speaker representing the Minister of Finance, we are trying to achieve universal health coverage. Most countries in the world are trying to achieve this noble objective, which was launched by WHO sometimes in 2008, and later being emphasized further with the launching of the Sustainable Development Goal. And related to achievement of the universal coverage is that we need to provide adequate resources. So sustainable health financing is very important, and I think Indonesia is one of the few countries which are very lucky in developing world because you have established your own health financing system through the Jaminan Kesehatan Nasional. While having the resources for healthcare, we need to ensure that the resources are being used efficiently. And one of the major strains that facing most of the health system is the increasing prevalence of chronic non-communicable diseases. And we can also see from what being presented by the first speaker, most of the diseases that affects population of Indonesia and also many parts of Southeast Asia and ASEAN regions are mainly chronic diseases, mainly diabetes, hypertension, stroke, and also ischemic heart disease, which are very difficult to manage. It needs a lot of preventive activities, as well as those who suffer needs to be treated for life, and that requires a lot of resources. And the fifth factor, which are very important for us to that we realize today, is the management of the newly emerging diseases, and we can see that in case of the situation of the COVID-19 pandemic now, we are facing this pandemic with the affects all the country in the world, and it needs a lot of resources, not only financial, but also human resource that affect the health system. So if you look at the COVID-19 pandemic, the situation was first started in China and discovered and being reported in December 2019. And then 3 or 4 months later, then WHO declared the pandemic situation that affects the world. And if you look at the statistic today, We have 15 million cases worldwide. 3 countries in the world have more than 1 million cases, which is United States of America, Brazil, and I think India. These are the 3 states. We have more than 600,000 deaths, and 216 countries, areas, and territories has been affected. The global economy was actually badly affected with this pandemic, where people cannot travel, businesses are affected because people cannot go and function as it is. In the first half of 2020, the GDP contractions accounted for as high as 7% of the global GDP, and it is postulated that probably by the whole 2020, nearly 3% of the global GDP will be reduced. And this is a lot in terms of the amount of resources that are lost through this system. Universal coverage means that we want everybody to have access to quality care, quality health services, without they having issues of financial hardship. And this is something which is very important for us to consider. And of course, we also know that there are 3 important dimensions of the universal health coverage. Services that are going to be provided under the population that are being covered, and this is very important. When you say universal coverage, the idea is that everybody will have access to quality services, but many countries are still having problems to provide the services to all the population, because there are still pockets of population that are not able to access the services because of their financial coverage, which means that we have resources to fund the services that are covered under the scheme. And we also been shown by the first speaker the issues of the deficit between in the National Health Financing System, your JKN, where the resources are not adequate, are not enough to cover the core services. And on top of that, people have to pay out of pocket, which is as high as 30%. Many developing countries are having the same situation, and worse still, countries that do not have the health financing system, which is in the form of, say, social insurance program, and they still have to pay a lot of out of pocket, and this is one of the major obstacles of having universal coverage. Let me see. ASEAN countries, there are about slightly more than 500 million people in the region, and we are quite, actually the population are quite young, more than 50% are under the age of 30, and the growth, let me move this a bit, it's disturbing my views. Yeah, okay. You want to move? Hold on a second. The economic growth is about 5.2%, and okay. We know that in ASEAN we have a diverse geography, and then we also have different cultures and different level of economic development, and hence the universal health coverage achievement is also quite varies. We have countries that achieve universal health coverage. Other countries are still trying to reduce the social inequities and trying to promote and achieve universal health coverage. We have countries that have a very advanced healthcare system, like Singapore, for example, and which have been able to provide a lot of resources. They spend quite a lot. At the same time, there is a lot of contribution from the private sector for this country, followed by other countries where the idea is to provide services through the government facilities like Thailand, Brunei, and Malaysia. Of course, other countries that have a social insurance program, such as Indonesia, Vietnam, and Philippines. We have our poorer countries in the region, such as Cambodia, Laos, and Myanmar, which are still having to struggle to provide these services for their population. So if you look at the achievement of the universal health coverage in ASEAN countries, it is quite different. Some has achieved, others are still trying to carry out the activities to achieve that. And then if you look at the globally, lower income countries, middle income countries, and high income countries, the pattern of the source of financing are different. While in high income countries, especially in the European region, as well as in the Americas, they are covered by the social insurance program. Even especially in the European region, most of the countries in Europe have got a very strong social insurance program, especially countries like Germany, the NHS system in UK, and also France and other countries. Middle income countries and low income countries still have to depend on two main sources. Number one, you have to depend on the government budget, which come from the taxation, and low income countries are still have to pay out of their own pocket. So out of pocket payment can be the main source of income, a main source of health financing, and that might affect the ability of the country to provide the services to all the population. And we can also see the variation in terms of the total health expenditure by various countries. But there are also countries which are very poor, such as, for example, Cambodia, although it spends nearly about 6% of GDP, but the amount that goes into healthcare is very small because this country have very small GDP. All in all, I think it's between 3 to 4% of GDP, which is very much lower compared to the global estimates. In the world, if you combine all the countries in the world, it is around nearly about 9%, 8 to 9% of GDP. And of course, OECD countries spends a bit much more than that. So this is an important aspect that we need to consider. Hold on a second, I have a problem to actually move the slide. It's frozen somehow. Okay. This is the out-of-pocket expenditure. In some countries, as high as 45%, Philippines 50%, and you see Myanmar 76% of the health expenditure come from out-of-pocket. When this is the situation, then a lot of people would not be able to pay for their services, and that is a very important aspect that we need to consider. Health economics and financing is a very popular areas in any health system. And when we talk about this, we can see there are a lot of people who are interested in this, a lot of institutions are interested in this, including the public providers, the consumers, of course, Ministry of Health, and also the industries, including the drug industries, insurance industries, and then people in the trade unions, and of course, the politicians. So what are the different types of health economics and financing research that can be done to contribute to the policy development and also to contribute to the policy debate in the country? The basic health economics research includes just doing a cost analysis where you quantify the resources that are actually being used to provide certain services. Although it looks simple, but it is very difficult to do because there are many challenges in terms of the source of data, technicalities, and all that. And then policymakers, when they want to decide on certain modes of management, they need to understand the effectiveness, and most importantly is cost effectiveness. So cost effective analysis, cost minimization analysis, and cost benefit analysis. These three clusters of economic research are very important. And the most popular one among these three are the cost effectiveness analysis. Cost benefit analysis has been done somehow, but it is not as popular as the other two. And cost benefit analysis needs a lot more data and also a lot more challenges in getting the value of human activities in looking at the putting dollar and cents to the human life. Many countries are also doing economic burden studies. For example, during COVID-19 outbreak, countries are looking at how much they need to spend to manage the epidemic, and this comes under what we call the economic burden studies. Other studies that looked at budget impact, this is important, when the intervention was proven to be cost effective. Normally, policymakers would want us to conduct budget impact analysis to see what would be the budget required for the new intervention and how you want to actually introduce these new services while taking out the services that are not cost effective, and how you balance that within the budgetary situation in each organization and each country. Health financing options is still a major choice for health economic research, especially on financing. And many countries are looking at the effectiveness and also efficiency of the social insurance program. And many countries are also looking at the various options of provider payment. I think in Indonesia, the hospitals are being paid using the case mix or the DRG system. Other countries, sometimes they pay the hospitals are paid using fee for service, and in some other countries they were using a mixed method. I think the provider payment method is still one of the very popular kind of research that being conducted to guide the policymakers. What are the barriers when we are talking about research in this specialized area within the health system? Number one, of course, there's lack of expertise and interest in developing countries. To be a good researcher, to conduct research in this area, you must be trained or take some courses and become something like a health economist. And this is very rare because to go through a formal training to become health economist, it takes a lot of time. And the other component is that the other sort of expertise that are needed is the policy analyst. This is very important. People who understand the different intervention and also the different policies. We need to analyze this from all perspectives in order for us to come up with more detailed information that can help the decision makers to make decision. The second important barrier to this research is lack of funding. Who should fund for research? This is always a problem, especially in university when we are trying to conduct research. We try to apply grants from various parties. The government have very limited resources. Sometimes the researchers have to get funding from other entities, including sometimes drug companies, pharmaceutical industries, and also other insurance agencies. And sometimes these funding that are given by these entities are not value-free, which means that sometimes there are a lot of conflict of interest by the funding agency, and that have a lot of ethical issues that need to be sorted out. That's why when we publish papers, we need to inform the journals that who actually funded this research and what are our conflict of interest. We have to declare it in order for us to be able to publish it, the paper properly. The third important barriers is actually poor coordination and networking among researchers. It's very difficult to get international networking going, and they need a lot of support, a lot of understanding between various groups, and this is not easy to be done. And real networking is very difficult, especially when people have different interests, different expertise, and then sometimes different cultures in doing things. There are also issues of networking between the health and non-health sectors, and this is very important. I will talk a bit about the coordinations with non-health sectors, especially when it comes to the data sharing. This is the amount of expenditure on research and development. GERD is actually the general expenditure on the research and development as percentage of GDP. You can see more developed countries such as Japan, Korea, and US, they spend nearly about 2 to 3%. Japan spends nearly 3% of GDP on research, whereas countries like in Asia and middle-income countries spend hardly 1%. Malaysia spend about 0.6% of their GDP. Indonesia is 0.1%. So the competition is great to get this funding running, and this is something that we need to look at and become a major stumbling block for us to conduct any research related to this. What are the human resources required in R&D? So you can see that a country that spend a lot on research and development fund also have a lot more people who are trained in research. So this is the number of full-time equivalent researchers per 10,000 workforce and also per 10,000 population. You can see Japan, compared to Malaysia, for example, we only have about 9 per 10,000 workforce, whereas in Japan, they nearly have about 10 times more than 10 times, about in terms of the number of people who work in the research and development. Hello? Can you hear me?
Yes, yes.
Okay,
Can
good.
hear you.
Yeah. The other barriers to health economic and research is bureaucracy. when we want to conduct research, we need to actually prepare a proposal and then obtain permission to conduct this research. And sometimes research related to policy and management is very sensitive. And sometimes we receive a lot of rejection from the interested parties or people affected by research that they do not want us to conduct this research because they are very scared that we might expose their weaknesses. And this is a major problem. And sometimes we have poor cooperation from potential respondent because sometimes the respondent can be people from Ministry of Health or from other entities that are involved, and they felt that they do not want to actually participate because they might be criticized by or being given a negative remarks by their superiors. Limitation in publication and dissemination is also another problem. First of all, to write good papers and to in good journal is very tough. After completing your research, you need to have a very good ways of writing this, and sometimes papers from developing countries are very difficult to get into journals of high impact factors such as Lancet or New England Journal of Medicine or BMJ, for example. And we tend to actually being able to provide this or publish this in the lower ranking journals, and hence the dissemination will be, or the awareness about our publication will be much lower. So we need to actually improve this. And the other thing is that in some countries, the publications of any paper related in the study need to be approved by the authorities. And this sometimes creates a lot of trouble. First of all, it will delay the process, and sometimes they do not want us to report something which they don't like to hear, and that is very important, important part. So at the end of the day, the results, which are real study done on the ground, cannot be published, and hence it will not have much impact in terms of improving the current situation. I have a lot of experience in dealing with this, and I think things are much better now than before, but still there are a lot of limitations from the bureaucratic part that actually have put a barrier in doing good research and publishing good research. The fourth point is that limitation in routinely collected data. When we want to do research in economics, financing, and policy, sometimes we use data which are routinely collected. Sometimes there are problems if you want to use the data that already been collected through a normal or through a regular survey by the government, because the information that are in the database that we are dealing with do not have the information that we want to answer our research question. Sometimes the data that are being collected through the national survey are of a poor quality, and this actually put a lot of barriers on us researchers if we want to publish or create studies from secondary data. Over the years, especially last 2 or 3 years, people are talking about big data in health system. This includes data that come from the electronic medical record. Many hospitals and health systems have already the electronic medical record being used. Claims data from social insurance program. You have a big data sets in the JKN in Indonesia. Surveillance data, mortality reporting, morbidity reporting, and in some countries, we have also the patient safety reporting. These are all mega-sized data which are potentially be able to be tapped by the researchers who are interested in do research in health economics and financing. But having said that, there are a lot of problems. Although the data is big and lies somewhere, sharing of data between various entities is normally a major problem. For example, even in our COVID-19 outbreak, for example, in many countries, Ministry of Health are the one that manage the cases, and they do not want this data to be shared with the researchers in universities. So the mentality of working in silos is very much prevalent in our organization, especially in the health sector. The reason for lack of data sharing is that they might fear that it might expose the weaknesses in their management, fear of losing power, and at the same time, there is no clear policy on guideline who owns the data. But data which are of patients managed by the health system belongs to the people, because people who collect this data are being a salary of the government, the government employees paid by salary by the government, and it comes from the taxpayers. So it's owned by the taxpayers. But having said that, some people thought that they own this data because they work in the organization, and as a result, they do not want to share this data. So people who have the capacity to manage big data and to do what better analysis are in the universities or in the institution that are being trained properly in research. And we actually lost this opportunity because people who actually own the data do not have the expertise. Those who have the expertise actually do not have the data to actually do a good research. So these are the some issues that we need to understand in terms of the challenges that are facing the researchers in doing research in health economics and financing, and also in health policy in general. So in conclusion, the first point is that we know that research in health economics and financing draws attention of many stakeholders, including, of course, policymakers. Secondly, we know that if we do good research in health economics and financing, it will benefit the whole healthcare system, where we can identify where are the areas that is not cost effective, where are areas which is not efficient, which we can improve the system on the whole. Solution to issues of quality, equity, efficiency, and accessibility can be achieved through research in health economics and financing. In doing research that deals with the issues of quality, efficiency, and accessibility, which all relates to universal health coverage, normally relates to health economic and financing. And we need to continuously and build human resource capacity and coordinate our efforts in these countries in conducting research in health economics and financing. I would like to end by thanking the organizers again for inviting me to give my this keynote address, and I would like to congratulate the organization UNES for organizing this important conference. Thank you very much.
Thank you very much, Professor Dato Syed Muhammad Al-Junid, for the speech. I do agree that one of the major barriers in health economic and financing research is bureaucracy. It's similar case here. I think it's similar case in Asian especially. Thank you for the informative and very comprehensive talk, which is really amazing. Anyway, Prof. Al-Junid, we are really eager to have a research collaboration with you in the area of health policy. We do have some researchers and young lecturers here who share similar interests with you. If you don't mind, I'd like to share your contact to our colleague. Thanks again.
Yeah, you're welcome, and I look forward to collaborate with anybody who are interested in this area.
Yes, thank you very much. They all are here. They all are watching on your presentations. All right, ladies and gentlemen, that was the end of the keynote speech session. Before we move on to the next agenda, we would like to remind you, especially all the presenters, to please change your Zoom account name according to the assigned room as we have announced in the text and email broadcast. It is letter underscore your full name. For example, A_Fatona Suraya, and so on, okay? So please change your name now because we are going to split the room after this. Okay, now we have approached to the very moment that we have been waiting for, plenary sessions, which will be moderated by our young and talented lecturers in Sports Science Department, Sports Science Faculty, Universitas Negeri Semarang. His expertise and research interest is in the area of exercise biochemistry, fitness, and health. Let's welcome Assistant Professor Muhammad Arif Ali, SSI, MSc.
Thank you very much. Raya, can you hear me?
Yes, I can hear you well.
Okay, thank you very much for very nice introductions. Our Master of Ceremony, Ms. Fatona Suraya, again. My name is Ali, and I am so honored to be your moderator for the plenary session 1. Let me do the share screen. Okay. Okay, first of all, let me read the rule for the participant. So the rule number 1, again, please turn on your camera and turn off your microphone. Second, do not sleep during the webinar. Question can be asked by the chat menu on the below, and in the end of the webinar, it will be informed the URL or the link of the attendance and evaluation form of ISPHE 2020 for issuing the e-certificate. So stay tuned on the Zoom and YouTube. And the URL or the link is activated only 60 minutes after the second plenary session is over. In this session, we have 2 invited speakers, one from National Institute of Education, Singapore, Professor Michael Chia, PhD, and he's going to talk about school-based intervention to physical activity, exercise, positive physical educations, and sport experiences. And another one come from Taipei Medical University, Associate Professor Syed Abdul Shabir, PhD, and his topic is about the use of technology to improve health literacy in the community, opportunities and challenges. In these sessions, we do have only 70 minutes. First 30 minutes for Professor Michael Chia, and then the second 30 minutes for Professor Syed Abdul Shabir. And the last 10 minutes is for the Q&A sessions. Before we begin, let me throw you a question. So, related to our first invited speaker, how can we encourage people to do physical activity, to do exercise or experiencing sport, especially for students in this pandemic time? Professor Michael Chia, PhD, his expertise is in physical inactivity, sedentary behavior, pediatric exercise, and he earned his PhD degree from University of Exeter, United Kingdom, in major pediatric exercise science. He is targeted to be the right one for us to deliver proper knowledge in school-based intervention to physical activity, exercise, positive physical education, and sport experiences. Without further ado, please welcome Prof. Michael Chia, PhD. The screen is yours.
Thank you very much, Muhammad Ali. Let me just try to share the screen. Are you able to see the screen? And can you hear me? You can, right. Thank you very much again. Not quite this one, yeah. Before I start, I'd like to thank Muhammad Ali for the kind introduction and also thank the organizers for inviting me to this webinar. I think it is very important and I'm indeed very honored. This slide shows where we are. Singapore is usually the red dot, but this one is green. But as you can see, Indonesia is very large. The number 47 is that you are 47 times bigger than we are. But we are great neighbors, so I'm really very privileged to be able to share some of my insights, but at the same time also learn from you. I was asked to share on this topic, which is school-based interventions, because over the years, I've been very fortunate to be able to do quite a lot of school-based research in terms of activity, either promoting activity or discouraging physical inactivity. And today, I will share 3 different examples that are a little bit more recent. I'm fortunate to come from a university that is ranked #1 in the last 6 years in the top universities under 50 years old. And in terms of QS, we're ranked 13 in the world. Basically, we train PE teachers. That's where I come from. The academic group is physical education and sport science. So I can understand that for today, you have been sitting for the last 3 hours. So I will encourage you, especially for webinar, you can actually not remain sitting down all the time. You can stretch like I'm doing now, as you listen. So that's the problem with our society, even though many, many useful things are accomplished when you are sitting down like this webinar, we're listening actively, but sometimes too much of a good thing can be bad. So today's coverage, I would like to share some insights in terms of there is a difference between physical inactivity or exercise insufficiency and sedentary behavior. So, and I'll share some of the research that we've done in terms of these two attributes, sedentary behavior and exercise insufficiency, which are two different constructs in preschool, primary school, secondary school, and just pre-adults, 17 to 18-year-old students. I would share, as I mentioned, just 3 different case studies. One is talking about what are the ingredients of quality physical education in Singapore. This was an invited book chapter in Oxford University Press, from the point of training of the teachers to the actual delivery of the program. And then, of course, like most societies, the education actually continues beyond the school year. So lifelong type of learning for activity, something that is life deep and meaningful and life wide. And I'll share 2 other research case examples: Pride for Play, which is case study 2, and SIT. In this case, SIT stands for short interval training. And I'll share a little bit of the research in early childhood that is still ongoing, and Indonesia is a team member of this international collaboration as well. So just a short video to show you what I want to talk about.
So Professor Chia, the video is played well, but we can't hear anything.
You can't hear anything?
Yeah.
Oh,
inaudible.
Okay. Okay, never mind. Let's try another one. Okay, this is an important slide. Can you hear me? Can you hear me clearly, Ali?
Yeah.
Okay,
I can hear you.
Okay. So yeah, differentiating, I mentioned that physical inactivity and sedentary behavior is not the same thing. So when you describe somebody as physically inactive, what we actually mean is that they do not meet physical activity guidelines. And we're quite familiar with physical activity guidelines, especially those of us who are in health and in physical education as well. So there are different guidelines for different groups. Here is an example from England. Of course, Indonesia, you have your own guidelines. And in Singapore, we have our own guidelines. And World Health Organization also has guidelines that are age group specific. So I give you an example. If you say a child, if you are say 11 or 12 years old, you fall within this age group, the guidelines for activity is that you should try to accumulate 60 minutes of physical activity every day. And then a young adult, if you are 30 years old or 21 years old, the recommendation is 150 minutes of moderate aerobic type activity. And then it goes on even for the elderly. Of course, it's safe for you to exercise, you get medical clearance, especially if you're after 40, it's 150 minutes. And then together with that, because they are aging and muscle wastage or sarcopenia is a problem, they also advocate strong strength training exercises 2 of those weeks. So if you don't meet these guidelines, you are deemed as physically inactive. And if you do, you are said to have met the activity guidelines. Now, what is problematic is actually sedentary behavior. So for example, like now, what we are engage in is sedentary behavior because we are just active listening and looking at the computer screen. And even if you are stretching, it's also sedentary behavior. So sedentary behavior, for simple understanding, is any kind of behavior when you are not sleeping, like now. So it's quite interesting. Your guidelines say, don't sleep. This is not the time to sleep. Yeah, but you can, shut your eyes and listen, that's fine. So if you are any waking behavior that involves sitting, which we are, reclining or lying posture. So there is a postural kind of criteria, and that results or does not consume very much energy. 1 MET is a reference, or 1 metabolic equivalent. 1.0 is the amount of energy you expend while at rest, when you are not digesting food, and when you are in a thermal neutral environment. That means you are not shivering, not too hot, not too cold. So any behavior that is expending less than 1.5 METs is classified as sedentary behavior. So clarifying that is useful. So the current situation in Singapore, as in all my years of doing work, so this is a preschool study, age up to 5 years old. We are finding that they are very sedentary and they do not meet guidelines. Many of them do not meet guidelines for physical activity. They also do not meet guidelines for screen time. In fact, they're spending too much time on screen on a weekday and on a weekend day. And they do get enough sleep. So they are now what we call World Health Organization integrated guidelines for sleep, for physical activity, and sedentary behavior. And I shall say a little bit more later on. This other study is so this is also an online survey. So this other study is a group of self-reported survey for adolescents. So this is a typical day as reported by 15-year-old students. So they are teenagers already. So 5 or 6 hours per day at school, 35 minutes up to 40 minutes per lesson. There's a break time for recess, and then 70 minutes of physical education. So based on their reporting while they are in school, 95% of the time is sedentary behavior. And for those of us who are interested in objective methods, you might say that, but these are self-report, and self-report questionnaire measures, people tend to over-report the good things and under-report not so good things. But even with objective methods using step counters, we found that in all age groups, in other words, from primary school, meaning up to from 7 to 12 years old, and from 12 to 18 years old, in terms of the number of steps accumulated, they are insufficient steps. The recommendation coming out from New Zealand, because we don't have Singapore guidelines for step count for adolescents, is 16,000 steps per day accumulated, and 13,000 steps for girls accumulated if they want to stay within the healthy BMI range. Today, we heard about from the keynote speakers in health economics that too high a BMI predisposes us to cardiovascular diseases. And in many countries, including Singapore, cardiovascular diseases, stroke and cancers are #1 killers or causes of premature death. So in the case of Singapore, this is worrisome also because they fall short by near 33%. In other words, they are physically inactive. And as you can see, we have very nice playgrounds all over Singapore, very safe, but many a time they are empty. And then most of the time you are spent in the classroom, whether it's for work or for leisure. And as you can see, there's a lot of screen time in school and outside of school as well. So this slide just shows that sedentary behavior or sedentary time, screen time, sitting time, all kinds of work, including academic work. When we do a lot of writing, we do a lot of presentations, preparing for presentations involves a lot of sitting time and non-physical work. So in this seesaw, the number of hours spent, if you bother to quantify, is many, many times that of the non-sedentary time, right? So in terms of how much time we devote to sport and exercise, even among ourselves and even among athletes, because it's maybe 2-3 hours if you're lucky. For most of us, maybe less than even half an hour. And active transport, very few people walk long distances these days. I know in Singapore, in Indonesia, the motorbike, the bicycle you still get some exercise. And in Taiwan as well, lots of motorbike, not so many people cycling anymore. And manual physical work, of course, is still taking place, but mainly given to foreign laborers. You know, in Middle Eastern country, even in Singapore, the people who do the manual work tend to be foreigners wanting to make a living. And in Singapore, as you may have read in the newspaper, they are also a vulnerable population in terms of living conditions, very cramped. So in Singapore, the COVID-19 situation, most of the cases are in the foreign dormitories for foreign workers. But of course, the government has stepped in and we're clearing and giving them the best medical care and improving very much the living conditions. So the situation is improving, but we are still not out of the woods yet. This is a nice slide that shows you this cartoon is very real. When we talk about playtime, these days, if you talk about young people, the playtime is screen time. You can see the seesaws and all, and the field, nobody's running around. Caution, because there are eyes on the screen. And every day, every time, the awaking moments, you are checking your screen. I'm just wondering how many of us at this webinar from time to time are checking our screens at the same time. Sometimes for work, but sometimes we multitask. And last year, I found out also, you know, that cyber gaming is very popular, especially among the young people, teenagers. So we have World Cyber Games, and the SEA Games last year hosted in the Philippines featured as a competitive sport. It is now in the SEA Games. And we have a very famous singer. Some of you might know him, J.J. Lin. In today's newspaper, although he's a singer, he formed his own cyber team to compete in competitions. So the world is changing, and even now competitive sport, cyber games is there. In Singapore, we have long debates about this, and now they are asking sports scientists how to support the cyber gamers like elite athletes to help them get fit for cyber games. You and I know that it is extremely, extremely difficult to be off screen, and sometimes young people don't have a choice, because the minute they can understand language, they see their parents, significant others on screen. And is this, I ask you, is this the situation for us today? How do we discourage screen time in the house? Have a look at this. Please, this is meant as a joke and good humor. Women, please do not go home and slap your husband or your boyfriend to offer the phone. This certainly does not happen in my home, but it is very, very true. It's very hard. And we as adults, I think we have to model positive behavior as much as possible. Right. So this is one of the studies that we have just recently submitted for publication. So this is about parents' association between parents' attitudes on on-screen and off-screen behaviors. So off-screen behaviors would involve indoor play, outdoor play, non-screen activities like reading, not from a screen, but books, doing craft work like painting or making tiny models and so on. And this is a situation that we all can relate to very much during the COVID-19 situation, where especially when there is a lockdown. Indonesia, you have experienced that, Singapore for sure, and many parts of the world. we have been locked down previously for 2 months. And I have a very interesting observation. So when there is a restriction in movement, the government, it is within the law, you should stay at home, but you are allowed to go out to exercise. So when I went out by the river, Singapore has very nice parks. When I went out during the circuit breaker, that means during the movement restriction, I can see that many people were out jogging or walking by the parks. Now we are no longer in the lockdown. It has been 1 month that we are now free to go back to.
Hello, Michael.
Yes. Can you
Okay.
hear me?
Yeah, but a little bit disturbance. So can you repeat again, maybe?
Okay. Sorry about that. I'm just saying that during the lockdown period, we are allowed to go out to exercise. And during that time, the parks are very crowded. More people were exercising. And now that there is no more movement restriction, I go back to the same park and I see the number of people, it was just yesterday, go down by 2/3. So yeah. So back to this study, in our study, we managed to get responses of about 3,000 parents, of which 70% of them were mothers, 30% were fathers. And our results show on a weekday and a weekend day, there was a significant relationship between the use of screen by parents and that of their children as well. Sorry. Oops. Why is that? Okay. So case study 1. So this is a paper or book chapter that we were invited to publish in terms of we were asked to comment in terms of how do we prepare PE teachers in an increasingly sedentary world and the idea of what constitutes quality physical education. So everywhere in the world, including Singapore, and I'm sure in Indonesia as well, we know the value and the importance of physical education. And physical education has very good goals. They help young people discover a love for physical activity. We help them to get them interested in activity, and then hopefully they get to practice the skills so that they can enjoy sport, not just when they are young, but when they finish school, and that they can play sports among themselves. In fact, there is a goal for us. By the time they leave school, they should be able to play 4 team sports in Singapore, and that is through the physical education program. But more than that, physical education is not just related to activity, fitness, and conditioning. They learn life skills, and this is extremely important. Through sport and games, they learn teamwork, sportsmanship, problem-solving, creativity. And even if you see university orientation programs, many of these programs, not just for PE students, involve sport and games, so that it is a natural avenue for people to bond. And even in the older age groups, in the elderly, it's important to get them to socialize. One of the keynotes mentioned, I think Indonesia is an aging society in 25 years' time. But in Singapore, we are already an aged society, ourselves and Japan. And it's a big problem because apart from activity and health, if old people stay at home and they are by themselves, there's a danger not just of sarcopenia, which is muscle wasting, so they become weaker and weaker and have to depend on other people. It is also a problem of the mind, so dementia can set in if there's no intellectual stimulation or if they are not involved with a good social setup. And of course, we want to imbue healthy habits for healthy lifestyle. So one of the reasons, one of the key things we were advocating all over the world and in Singapore as well, is that we have to work together with stakeholders. Teacher preparation, which is the NIE, National Institute of Education, we prepare teachers, but they after training, they go back to schools. And when they are in schools, we have to work closely with the schools. So whatever they learn in teacher education can be translated into practice. So there is a very close coupling or relationship together with the Ministry of Education. So in fact, some of the programs that we curate as professors, we work together with the Ministry of Education as well to come out with programs that should be taught at university so that they can be translated in school. So we also have an apprenticeship scheme to be in schools where we work closely with the schools where the PE is experienced. So one of the success factors we're trying to get at is that Singapore being a small country, perhaps we have good advantages and all the key institutions work together. I must say that it is not always easy, but that is our working model. So there is a lot of negotiation, there is a lot of mutual respect as well. So that's the first case study. So case study 2 as an example, we all know that children love to play. And when I talk about play, I mean physical play. So even if we have physical education twice a week, that is really not enough. In proposing this topic, we said, how many times do we eat a day? Well, generally, most people schedule meal times 3 times a day. I know in Thailand, I saw a documentary, depending on where you are, sometimes normal people eat 5 times a day. And you know, it's great hospitality. There's a lot of snacks and so on and so forth. But when you talk about activity or playtime, even when I was growing up, playtime is usually left to the last part. My parents would say, you know, only when you finish your homework, only when you do your household chores and everything else. So I always look at the time, 4:30 is playtime, and I always look at the clock wanting to go out. So I know how it feels. So how would you expect people to be physically active when it is not a habit? So in proposing this, what we were suggesting is that there should be playtime every day in the school day. Now, this is really, really very tough. So Pride for Play stands for, as you know, personal responsibility in daily effort for participation in lifelong activity for youth. So when I proposed this, I had to spend a lot of time talking to the principals and encourage the principals, how do we have a playtime in school? At primary school level, they have 10 periods a day, and 10 periods a day includes recess time. So, and each period is 30 minutes. So I proposed to the principal, can you make each period 27 minutes? So with 10 periods, you get an additional 30 minutes. And over and above the PE time, the children come out to play in a school environment that is safe, there's good equipment. And guess what? The teachers also come out to play with the children. So when I spoke to the teachers about this, the first thing they said, what would my school principal say? And then I went out and I got in the school principal, and the school principal told them, of course, I had already spoken to the principal. He said, if you support this program, you will have a very good appraisal. So it has to have the school buy-in. So this was, in short, it was actually a pilot study over 2 schools, and it went on for 1 year. So as you can see, the children were extremely happy to be part of this program. And at the end, when we collected the data before pre and post, we found that there was increase. The teacher got along better with the pupil. There was great enthusiasm for playtime. So often when a teacher was talking and it went past the period time, the children will remind the teacher it is time to play. Now, this portion here is very important because in Singapore and many other countries, especially in Asia, academic work is very important. So if you were to monitor the conversation between teacher and pupil, it is very, very often about academic work. But when the teacher and the pupil came out to play, for example, table tennis or badminton, the teacher got to learn another side of the pupil, and the pupil also got to learn another side of the teacher, that teachers can be fun and teachers can be mischievous, that teachers are not the monsters that they make them out to be. And of course, some of the academic teachers will say, if they play more, won't it affect their academic results? So we also monitored the academic results, and we are very glad to report that there was no drop in academic results. And how do we know? We compared it with a school without this program, equivalent school. So they are side by side, the school. One school control group, no program, just normal academic lesson and PE time. And this school, the intervention school, has this daily play time. And then there was also the worry that maybe if children play more often, maybe they will fight and more discipline cases. Again, we monitored the discipline cases. There was reduced actually discipline cases and no increase in accidents as well. So it's all good. But there were some key success factors, and I cannot overemphasize enough. The key success factors is that you need the whole school buy-in, that there was a clear vision. We take a long time to co-curate this with the principal and the teachers. And it was understood by all the form teachers. Fortunately, in the two schools that we work with, the teachers were very young and enthusiastic, and there was a proper structure and monitoring of the program as well. By the way, at National Institute of Education also not just train PE teachers, but we also train all the principals. So we get to give some input as well. I'm coming to case number 3. I'm mindful of the time as well, so I want to leave more time for Q&A at the end. Now, not all physical activities we expect to get some results, and I'm going to share with you. This was again a recent study that we have just done. We call it SIT, meaning short interval training. So we scanned the literature and we came up with a project that say that 20 seconds of high intensity sprinting or cycling will help to improve alertness, the mood and memory. Why alertness, mood and memory? Because these are the prerequisites or ingredients of good learning. So if you are paying attention, if you are alert, you learn better. You can listen to what the teacher is saying and maybe you can absorb better. If you are in a good mood, or rather if you are in a bad mood, I'm sure no matter what the teachers are saying, you or your friends are learning with you, you will not be learning. And verbal memory is important because just like now, if someone shares a discussion, do you remember some of the key points? So, and we studied female children in primary school. That means 7 to 12 years old, and this one 13 to 18 years old in adolescence. So altogether 4 minutes, the title is 4 minutes of interval training, had no short-term effect on improving alertness, mood, or memory in female students in primary or secondary school. So quite a large number of students that we had. So control group, normal PE lesson without the 20-second sprint. The experiment group, normal PE program, together infused with the short interval training. So the protocol is 3 sets of 20-second all-out shuttle sprints. That means to and fro with 60 seconds active recovery walking. And then we took measurements in the third session. So we asked the participants to complete 10-point scale, hedonic scale, just 1 to 10 on mood alertness. So they rate their own mood and alertness, and a verbal memory recall test. So to give you an idea of what a verbal memory recall test is, it's just 15 random words, 2 syllable. So things like taxi, yellow, river, right? So 15 words, I rattle off 15 words, and I ask them to listen carefully. And when I finish the 15 words, I would say recall now. And then they try to write down all the words that they can remember. So that's a verbal memory recall test. And we wanted to find out from the teachers whether if they had such a program, do they see it as feasible to conduct as part of their PE lesson. So altogether only 4 minutes. So our results show, yes,
Hello?
yes.
Yeah, 1 minute more.
Okay, sure. Okay, so no beneficial effects there. I'm nearly done now. So the important thing is that when we put everything together, we need to work as a team. I would say not just a whole of school approach, but a whole of ministry approach. And if you want to talk about lifelong carryover, we need a whole of government approach to problem solving. So if we say Singapore, I know Bandung is a smart city. So Singapore is in the same situation about smart city work. So sustainable management of activity regardless of time. So from doing a lot of smartphone to being in the streets, of course, make sure that it is safe. So this is again a cartoon. And I would say for all of us who are listening to this, that we don't have the solution, so you have to find solutions for your own country. So different treatment required for different culture context of each country. This is a very interesting video, the last 30 seconds. We need to resonate with young people in coming out with novel ideas. So these are 2 video clips that have gone viral in China. You can find out more about our international project by visiting ISPHE. So this is for early childhood. This is the research that Indonesia is also involved with us together with 19 other countries. I'd like to acknowledge my team for the research. And this is what I do on a daily basis to break up sedentary time. I try to do the number of pull-ups that are my age in years. So from this slide, you can see I like to dress up for my exercise, and I'm at least 35 years old. Terima kasih. Thank you for your attention, everybody.
Thank you very much, Professor Michael. Yeah, that was really interesting talk about school-based intervention, especially in Singapore. Now we are moving to our second invited speaker. However, does anyone know yet what the health literacy means? So health literacy is important for everyone because at some point in our lives, we all need to be able to find, understand, and use health information and services. Health literacy can help us prevent health problems and protect our health, as well as better manage those problems and unexpected situations that happen. Our second invited speaker is a association professor, Syed Abdul Shabir. A moment, please. So let me do the share screen. Yeah, so Associate Professor Syed Abdul Shabir expertise is in artificial intelligence, big data analysis, and hospital information system. He earned his doctoral degree from National Yangmei University, Taiwan, focusing in health informatics. We do believe through his talk about the use of health technology to improve health literacy in the community, focusing on the opportunities and challenges will give all of us better understanding how to enhance the use of health technology. Without further ado, please welcome Prof. Syed Abdul Shabir.
Hello.
Hello.
Assalamualaikum warahmatullahi wabarakatuh. Hope you
Waalaikumsalam,
are
bro.
hearing me properly.
Yeah, we
Okay,
do.
just give me a one second. Can you see my screen?
Yeah.
Okay.
Yeah, okay.
I don't see full screen.
Yeah.
Okay. Good.
Yeah, everything is
Okay.
good.
Thank you so much. Once again, it's my pleasure to get invited in this great event. And first of all, I want to thank distinguished lecturers, dean, directors, and most importantly, the staff working behind this conference, Ms. Suraya for inviting and interacting and doing all these interactions to make this happen. And then since morning, I was following the talks of various invited speakers and opening talk from the dean and rectors. Wonderful speech, and it made our day because we get more information on various aspects of health technologies, health educations, and health literacy. You see, these are like various words, but if you make a essence of that, it leads to only one thing, that is healthy life. So our ultimate aim of all these projects or all these events, talks is how you can make our life better, more healthy, active aging, all those things involved. So without further ado, I just go into the presentation. And as you see the technologies, because the main purpose, I am a medical doctor and I got interested in technology. Therefore, I thought of, okay, I cannot separate technology like Professor Michael was talking. Children are playing a lot with the mobile phones, with this, and they are not having a lot of exercise. So I was thinking, okay, how I can do where they can use phone and do exercise. They can use phone, so we call it like a m-health or mobile health, or we call like gamification. Gamifications in the sense we promote games using technology. We promote games and we give them some sort of medals, records, points, so that it make them motivated for continuing the do exercises. If you see the technology, you see like in 90s we had very simple phone. Maybe some of you not even seen, but yeah, people like us, we used to have these phones with limited functions. Then comes the smartphones, and now apart from smartphones, we are also having social media and wearable devices. And all these things are getting integrated and giving lot of data, big data. There comes the big data analytics and artificial intelligence for predicting and motivating the people and seeing how they can maintain their chronic issues meaningfully. As you see again, there is no difference between developing world or developed world. Everywhere you can see lot of mobile phones, smartphones, internet penetration. And now we are getting these connected things. That's why we call Internet of Things, like speakers, sensors, weighing scales and blood pressure, weighing physical activity, these things, Fitbits or watch. So you can have lot of activities which can be monitored and recorded just by using the wearable device. Now we can see how much a child have moved or walked or having physical activity, not only a child but also a patient. So I will give a few examples with the patients, how patients are, we are helping patients to motivate them to do better physical exercise. And this is what I was talking about, artificial intelligence of things, where we provide data analytics and we call it as the edge AI. That means there is some sort of algorithm working already in that device. I am sure some of you may have Apple Watch. If you sit for 30 minutes continuously, it says you, oh, okay, it's time for you to stand up or it's time for you to walk. So this is called edge AI. So by seeing your position, the device can know what you are doing. If you are not moving for a longer time, then it send you an alert saying, okay, now it's time for you to get up and go for a walk or just stand up. So this is called artificial intelligence of things. And there are a lot of various projects have been implemented and used to motivate people to do better physical activity. And this is again how our hospitals and rehabilitations are becoming so complex. You see, if you see here, a lot of activities, interaction between using, and everyone is using intelligent design methodology to connect each other and to give and smart, what to say, decisions and indications for the patients, for the healthcare providers to follow up so that they don't lose that time and they get appropriate information at the right time. And it's very interesting to see how healthcare delivery models are changing now. So if you see, before we had electronic health records or paper records whatsoever, then once we get into electronic health records, we get databases, then we are started connecting with the wearable device sensors, and here comes the data analytics. This gives clinical information, clinical decisions, and then we get this is very important, patient engagement and patient empowerment. So I have done a lot of research on how I can engage patients in maintenance of their own healthcare problems and how I can empower them using information and making them enlightened regarding their own problems. So I give you examples of patient supported through AI-based solutions. One of this is DigiQuit. Here we use mobile phone for the patients who are willing to quit. If you remember in the opening remarks, there was director Professor Pradhan talking about smoking and alcohol, all those things. So here, this is best example how we can motivate people in quitting smoking. So usually what happens in people who smokes, there are three categories of population. One category, they never want to quit. No matter what you do, they don't want to quit. They may quit their wife, their girlfriends, but they don't want to quit smoking. Second group of people are the people who needs to quit because they have already landed in the problem. That means they already have cancer, they have some surgery, they have COPD, but they have some issues with their health, and doctor wants, if they don't quit, they will die. There are third group of people who are willing to quit, but they don't have enough motivation. After 2 months, 3 months, they go back and start smoking. So this solution is for the people who are willing to smoke. So mobile solution to support pharmacological based smoking cessation. So they are taking medications to quit smoking, but they need some sort of motivation. So what basically we does here is, this is an app, and if you see here, first we collect some questionnaire, and we give, this is the dashboard of the software. The first dashboard is, okay, in 1 day, how many cigarettes you smoke? We take it from the questionnaire. So if I say 10 cigarettes, so 10 days you are not smoking. That means this will become 100. So 100 cigarettes you have not smoked in last 10 days. And then here is 100. And then how much money you saved out of these 100 cigarettes, that we will show as a dashboard. And then we say how much health you gain by quitting this. So what we do is we also send motivational messages, and that is tailored. That what I do mean by tailored is, we don't say generalized message like, if you smoke you will get cancer, if you smoke you will get ill. No, we will say, see, you are 23-year young female. If 10 days you have stopped smoking, if you continue, your skin will shine and you will become more beautiful. For males, we say, okay, if you stop smoking, your taste buds will improve and you can really feel the good taste of the food. Once you stop smoking, you feel the real taste. So there are a lot of motivational messages that we are providing, and this worked in our Taiwan clinic. These are the answers. The abstinences was like 41 compared to people of other medications was only 17. So obviously, I'm not saying it gave 100%, but it make a lot of significant difference. And you see, apart from that, we have made like behavioral design dashboard for enhanced user retention based on health behavioral change, gamification element, design validate, and end users in Spain, and this is Taiwan actually. So we use like iChange model, University of Maastricht to deliver the messages. And this is continuously, and as I told you, we don't send randomly, we send the messages targeting the population, the age, gender, and their pets and surroundings, whether they are married, whether they are pregnant, depending on all those things. And this is the algorithm how we used AI for that. We have published this. Here it is. If you want, you can go and see the details of this study. Next, I want to go for wearable device. This is another interesting topic where we get in market. If you go, you get lot of various wearable device. But the question is how you are using them, for what purpose you are using. Most of us use Fitbit just for fashion, just like a watch. And once a while, you just see how many steps you count, but that is not the real purpose. And here is the real purpose. It is all about behavior motivation. As I told, we can see your sleep quality, we can see your psychometric assessment, we can see the sentiment analysis and facial analysis. All these different type of analysis we can do just by using wearable devices such as Fitbit and all those things. The beauty of these devices is they record without doing any extra steps from you. Just you, what you need to do is wear the watch or wear the wristband. That's all. It directly automatically connects to your mobile phone. From mobile phone, it goes to the cloud. They do the analytics and they send back the information you needed. And this is another interesting solution which we are focusing, that is digital health data enhancing healthcare. So we are trying to capture various type of data and see how this help to improve the patient's outcome or patient's health. So we are taking mobile technologies, we are taking patients reported outcomes. All for this, we need to use again mobile phones or wearable device, and we collect all variable data, and then we integrate this data with the clinical data and type of cancer, and then we give you the results saying like patients are the most underused resource of information in observational studies. This is what we found out. And definitely physical activity and sleep evaluation using wearable, it's very easy. As I told you, don't need to do any extra efforts. Just you need to wear it and you get all results out of this. So clinical wearable devices are like actigraphy and consumable wearables. You get hundreds of them in the market. And what you need to do is that just to keep record of how your activity is changing from time to time. And there are like some positive things, negative things, like maybe it can be expensive, like more logistics, like charging, data sync, maybe the device design is not so good. These are the bad part. But the good part is robust and clinically validated, comparable with multiple studies, less concerned with privacy, no changes in software during study. So yeah, these were the few things. So I give one example from Taipei Medical University where we work with the cancer patients after treatment. So this was a catch, that is activating technology for connected health. Here what we did is we took 20 breast cancer and 20 prostate cancer patients. We give them our device, and what we did is physical activity for whole day and sleep quality for the night. And this is the device, how it looks, and it connects through Bluetooth to your mobile phone. And this is the actual device within this, inside this. You see, this is exactly what it looks like. And then it gives your data to mobile phone, it goes to the cloud, and we do a lot of analytics, and we come give back to the patient saying how much they are sleeping, how much they are physically active, and then we see the quality of life after treatment of the cancer. So this is the data which we get. If they are more physically active, it shows here, and this shows they are sleeping. And this is a sleep observation. Once we zoom in into the data, we can see the details of the data, and this is called awakening. This is the sleep. So we can see how much time they awake and how much they sleep. And once we do the analysis for 8 hours, we can view the quality of the sleep as a result. So the conclusion was like variable and questionnaire, actual sleep parameters affect sleep quality, providing personalized care to cancer patients to improve their quality of life. So what we did was, usually people with prostate cancer were sleeping bad compared to people with breast cancer, but clinically it's making sense because these are female young patients, whereas prostate cancers are elderly and old male patients. So the sleep quality definitely differ between them, but still we got a new idea of, okay, how we can deal with them. That means people with prostate cancer should be more focused on sleep, how we can improve their sleep, sort of thing. This is another interesting biopatch, we call it. It looks like this, which is connected to the sternum, and it gives a heart rate, mobility, physical activity of your body. And we even managed to calculate the breadth of your people using the activity. So it looks again like this. Similar things once we go into the deep. So this is the respiration things, signals which we collected using this biopatch. And again, this type of applications can be used widely for cardiovascular diseases, psychiatry, sleep analysis, preventive care, family medicine, and medical research. So just I want to reflect to what Professor Michael was talking about, elder aging population. Definitely, most of the developing countries are getting aging population. So what is the unique method or an innovative method is, we cannot wait them to get ill. We cannot wait them to come to hospital for treatment. So what we need to do is, we need to provide them tool, collect the data at their home, and at the first sign of any deterioration, we should go and approach. So we should send staff to the home rather than waiting for patient to get hospital with the complicated diseases. So as you see, the one of the conclusion is like there are multiple opportunities. Data-driven technology possibilities are rapidly growing and increasingly becoming available. The question is not what can be done, but what clinicians and patients need. So we need to focus on the need of the patients and the doctors, not technology as a solution. And then I want to finish my talk talking something on the MOOCs. MOOCs is nothing but open online massive courses, and which is like massive open online courses. In this COVID era, people prefer not to go out. They learn themselves sitting at their home. Ubiquitous learning, that means anytime, anywhere, when you are willing to learn. And again, social learning while having social distancing. So this is the importance of MOOCs. These are the MOOCs which have educated, delivered in our Future Learn platform. You can just go and Google any of these course and get enrolled free of cost. This is by Future Learn. Just you can go Future Learn and type this, you will get this course. And this is what I called social learning. What happened with MOOCs is, it's not only in lectures or the talks like now, people are listening. I see like more than like 200 people are there. They are listening to my talk, but some are having some other things to do, some are playing with their Facebook, some are doing the emails, and someone are listening carefully, but they cannot interact with me because again, limitation of time, limitations of resources, and what happens is they need to just stop whatever I told without expressing there. But if it is future learn or if it is MOOCs, they can listen to me at their convenience and they can interact with me, they can write their comments, they can discuss between learners. See, empowering the HIT tools, the social impact of aging. I see the noise, background noise. Okay. People perform better than when they are informed and introduced to healthy life technologies, gamification and education, the future of healthy living with technologies. So these were our publications. I don't want to go into the studies, but one thing which I want to emphasize is there is a lot of information available online. But I want to warn each and every one of these participants, there is a lot of misinformation also. We should be aware of the source of information. We should know. So this is one of the study where we found it's easy to find the information, but it is very difficult to take the decision out of that. This is how this study reveals. You see, to find 92%, like 61% says it's very easy, and what to say, only 14% say it's hard, but rest of the time they can find. But if you see to judge, only 36% say it's easy to judge online information because it's not so easy to judge whatever you see to trust that. So this is again detailed response to find the information and to judge the health information. So this is part of health literacy. So what is different between health education and health literacy? Health education is the information that you provide outside, but the health literacy is about the knowledge, the judgment you can do from the information you will get from the education you have done. So definitely, I don't want to go to the, as you see, finding online information is easy, but retrieving related information, all these things are easy, but judging is not so easy. Health consumer found it easier to search and find, difficult to judge the information. Low health literacy and other related skills, they have evaluated and trust online health information. So again, I want to end up with the key questions. Points to care extended to home via technology. This is very true in COVID. We want to take care back to the home of the patient. Then we should see how this new doctor-patient relationship, how the clinical flow and how whether these EHRs are ready. And then real-world data algorithms. So as I told, we are getting lot of real-world data around the world. So how we are making use of them and design of digital health and adherence support. So there is a high time how we can use digital tools for adherence, compliance of the treatment and medication. And definitely I want to thank my co-workers. These are my faculty members, which I am working. And thank you for listening. And once again, thank you for giving this opportunity because I managed to contrast as much as possible. So I took like around 20-25 minutes, I suppose, but I will be more than happy to take questions and answer for any participant.
Okay. Thank you very much, Professor Syed Abdul Shabir. That was a really informative talk. And now we are going to question and answer sessions. I already have some questions, and the first questions from Fitriana Prativi. I do believe that she is a postgraduate student at UNES, Universitas Negeri Semarang, and her question addressed it to Professor Syed Abdul Shabir. The question is how to change people behavior to get telemedicine than to meet the doctor directly. I think you may answer directly now, please.
True, yeah. This is the running problem now. So definitely we need to make various attempts to connect doctor and patient. So before COVID, the situation was totally different. But after COVID, the problem with the patients is if they go to the hospital, they will be surely getting the infection. So we need to try as much as possible to make the distance and connect them. As I told, there should be connectivity, but at the social distancing. So, and now it's the need. It's not like we are willing to do that. So definitely both doctors and patients understand. So, okay, you cannot go to the doctor, but you can see him, you can talk to him, and you can get your problem solved interacting with the doctor. So now things are becoming more easier because if you see what we didn't do in last 20 years, we can have done in this last 2 months in terms of telemedicine. Because it was not easy convincing users, patients, to stay at home and connect to the doctor using telemedicine. But now they want it. There is no other option. So it's the time, it's the need that has changed the mindset of the people, I can say.
Okay. Okay, here another question, still addressed to Professor Syed Abdul Shabir. This question is from Siddiq Purwoko in IHRD Magelang district. The question is, if we use too many gadgets, how will the radiation impact the gadget on our bodies?
Good. Very good question. We need to understand not every gadget is radiation. It all depends upon what is the technology behind this gadget. So I am more focused on actigraphy or like Fitbit. So they are using accelerometer, which has no radiation. It has nothing to do with the radiation. Radiation is with the old phones, I insist. New phones have very less, radiation. But previous phones where we used like 2G, 2.5G, they had huge radiation. So we don't need to worry because still, if it is a medical device, FDA are in charge of taking care of all these things. But we as a users, we should not worry so much. But definitely, it's a good question. You need to think about devices which are using radiation, which are not using radiation. So not each and every gadget is radiation. Short answer.
Yeah. Well, thank you so much for the answer, Prof. Syed Abdul Shabir. Now, the end.
One more question.
Yeah, one more question from Sri Sumartiningsi. She's a young talented lecturer from our university. The question is how to application on HRV to use. It is can do during exercise
Very
or
good.
just
Okay,
instant.
first of all, I want to give a brief introduction. HRV is heart rate variability. So what happens is when you use this patch, we get ECG continuously. It was impossible. If you remember few years back, if you want to get ECG, you should go to the hospital, you should lie down, you should remove all your, rings, watch, and then they connect you with the four, cathodes, and then they put 6 different cathodes on your chest, then only you will take ECG. From there, this watch gives me ECG of my hand. Of course, it's like single lead, but it is ECG. So now coming back to HRV. HRV is nothing but heart rate variability. So heart rate, if you see now I am giving a talk, maybe I am a bit nervous, my heart rate goes higher. You guys may be sleeping, some of you, they are not even listening to me. Definitely their heart rate is down. They don't even care. They're not much worried. So the heartbeat itself doesn't give any information. But heart rate variability, how much it is changing, it gives you lot of information of your sympathetic nervous system in your body, which reflects infection, which reflects any disease, which reflects your psychological status. Even in lie detector, people use HRV because intentionally or unintentionally, when you say lie, your heartbeat goes because you know you are doing something wrong or something like this. So this is the power of HRV. So definitely when we do exercise, we know HRV changes, but we can have algorithms differentiating HRV because of exercise, HRV because of infection. So it's not the same. What happened with the exercise is after 10-15 minutes, everything comes down once you start taking rest.
Yeah.
But in case of infection, it doesn't happen like that because infection is developing. So it maintains and even get bad unless until you get treatment. But it was a good question.
Yeah. Thank you very much for all the answers. I do have one questions addressed to Professor Michael Chia. As we saw the previous presentations, that children will always copy what their parents did, right? However, you also mentioned that in Singapore, the PE class is only twice a week. The question is how important the role of PE teacher in order to make the student become more active physically, especially in this pandemic time.
Thank you for the question. Can you hear me?
Yeah.
Yeah. So PE teachers, because they are professionals and they are trained, there is quite a lot of data, not just in Singapore, but globally, say, firstly, the PE teacher must be qualified and trained so that they can be a good role model and also conduct safe and fun physical activity lessons. And these days, it's a lot more challenging because we are competing. If you are talking about fun activities for play, if you ask children, how do they play? Very often it is a cyber version. And so it's important to be able to say, how can you be in a space and use technology or use what is in fashion to engage the children. So for now, one recent example would be like TikTok. Everybody talks about TikTok, right?
Yeah.
So instead of, like the teacher leading some of the activity, you can show them the activity. And then you can say, can you work in a group of 2 or 3 and come out with something, just 1 minute, you practice, you have some music. Better still, you ask them what kind of music they like, maybe Blackpink, and then, or something that is in fashion, and then they will say you upload. So you use the technology, and I like what Professor mentioned about the learning community in MOOCs. So it doesn't have to be MOOC. In this case, if you can orchestrate in a class and ask them to upload, and then you generate, some things on social media among the peers. Yeah, so that might be a starting point.
Yeah. Well, thank you. Thank you very much for the answer, Professor Michael Chia. So here is the end of the plenary session 1. May I deliver a little conclusion that I will say that the conclusion is the use of technology to improve health literacy in the community is also can be applied in the school for the student as well. Yeah. And I do apologize for any imperfection in this plenary session 1. Thank you very much for all the audience who are engaging with the questions. And thank you very much for Professor Michael Chia from National Institute of Education Singapore, and also Professor Syed Abdul Shabir from Taipei Medical University, Taiwan. Thank you so much, and may we see again in the future.
Inshallah.
Thank you very much. Thank you.
Back to you, Raya.
Thank you very much, Mr. Muhammad Arif Ali, for moderating the event. Thank you, Prof. Michael Chia and Prof. Syed Abdul Shabir for the wonderful presentation and discussion. May all of us get the fruitful knowledge from the lectures, and may this event could bridge more collaboration between us, especially in terms of research, joint publications, and guest lectures activity later. Ladies and gentlemen, I'd like to remind you again to please change your Zoom account name according to the assigned room as we have announced in the text and in the email broadcast. For example, A_underscore your full name, A_underscore Fatona Suraya. Please change it now since our operator already divided for breaking out room. All right. The next plenary session will be moderated by Assistant Professor Lukman Fauzi, SKM MPH. He is an epidemiologist and academic staff in Epidemiology and Biostatistic Division, Public Health Department, Universitas Negeri Semarang. He is also active in the Indonesia Public Health Association, IAKMI, Central Java Province. Mr. Lukman, the stage is yours.
Check, do you hear my voice?
Yes.
Okay, thank you, my college assistant professor Fatona Suraya, MA, for the opportunity given to me to guide the second plenary session in this international seminar. Good afternoon, ladies and gentlemen. I am Lukman Fauzi from Public Health Department, Universitas Negeri Semarang, and I will be serving as your moderator today. Welcome to second plenary session of the fifth International Seminar on Public Health and Education, ISPHE 2020, organized by Sports Science Faculty, Universitas Negeri Semarang, July 22, 2020. Before we get started, let me to announce again the rule for participants during the second plenary session. On the screen, you also might pay attention for the rule. Number 1, please turn on your camera and turn off your microphone. And number 2, do not sleep during the webinar. Number 3, you are allowed to ask the question by chat menu. And number 4, in the end of the webinar, it will be informed the URL or link of the attendance and evaluation form of ISPHE for issuing the e-certificate. So stay tuned on Zoom and YouTube. And for the YouTube channel, also you can fill the form of attendance and evaluation of ISPHE, not only in Zoom. And number 5, this link is active for only 60 minutes after the second plenary session is over. In the second plenary session, we have 2 speakers who will deliver speech about beating non-communicable disease in the community through social engineering with local potential approach. And the second topic is health education as an effort to enhance community participation to prevent environmental disease. The first topic will be delivered by Professor Oktiaworo, medical doctor, and the second topic will be delivered by Assistant Professor Nirwan Trumbu. Ladies and gentlemen, before we start this main event, let me show you and introduce the curriculum vitae of each speaker. Professor Oktiaworo Kasmini Handayani is from Nutrition Department, Sports Science Faculty, Universitas Negeri Semarang, Indonesia. She graduated her PhD from Development Study, Satya Wacana Christian University, Salatiga, Indonesia. And she already published and presented the research and article in lots of the international journal and international seminar. And her expertise in public health nutrition, local potential-based nutrition program, and social capital in nutrition perspective. It's important. And second speaker is Assistant Professor Nirwan Trumbu. Her nickname is Professor Ni. She is from Faculty of Public Health, Mahasarkam University, Thailand, and she graduated from PhD from Computer Science Investigated in Health Informatics, University of Southampton, United Kingdom. And she already also published and presented in the research and articles in lots of international journal and international seminar. And her expertise in GIS and health, Internet of Things, health literacy, and health information and technology. Ladies and gentlemen, due to time limitation, I would like to inform you that time allocation for each speaker to present is only 30 minutes. And after that, after all speaker give the presentation, deliver the presentation, I will open the question and answer session for the audience. You can chat by chat menu. You can write your question or discussion in the chat menu. Without further ado, I would like to welcome you to our first speaker. She will deliver the topic entitled Beating Non-Communicable Disease in the Community Through Social Engineering from Research to Local Action Indonesia. Please welcome Professor Oktiawaro Medical Doctor. The screen is yours.
Let me do share screen.
Yes, please, Prof.
Okay. Whether my PPT has been seen?
Yes, Prof.
Okay. Good afternoon, ladies and gentlemen. Assalamualaikum warahmatullahi wabarakatuh. In accordance with the theme given the topic, I would like to present is the local potential in non-communicable disease management, which was the result of our team research. Non-communicable disease atau penyakit tidak menular atau PTM, as we know, is a medical condition or a disease that is not caused by infection, thus it will not be transferred from one person to another. It completely different the word current condition COVID-19 is a communicable disease transferred through coronavirus. Or can be said a non-communicable disease or NCD is a disease that is not transmissible directly from one person to another. NCDs include Parkinson's disease, autoimmune disease, stroke, most heart disease, most cancer, diabetes, chronic renal disease, osteoporosis, Alzheimer's disease, cataract, and many more. To support countries in their national effort, then WHO considers the need to develop a global action plan for the prevention and management of 2013 to 2020 NCDs, which include 9 global targets. The main focus of this action plan is on 4 types of NCD: cardiovascular disease, cancer, chronic respiratory disease, and diabetes, which make the largest contributes to morbidity and mortality due to NCD. Based on research that has been taken to get that, there are 4 risk factors for behavior that are dominant and need to be attention, namely tobacco use, unhealthy diet, lack of physical activity, and the hazardous use of alcohol. Selain itu, kondisi di mana orang hidup dan bekerja dan gaya hidup mempengaruhi kesehatan dan kualitas hidup mereka. Those 9 WHO global targets focus on, among other, mortality rate, alcohol consumption, physical activity, salt consumption, smoking, hypertension prevalence, diabetes case management, and obesity, patient treatment and medical supplies. For example, target 5, target nomor 5, pengurangan relatif 30% dalam prevalensi penggunaan tembakau pada orang berusia 15 tahun ke atas, lebih, 15 tahun lebih. Target 6, penurunan relatif 25% dalam prevalensi tekanan darah tinggi. Dan contoh lainnya adalah target nomor 7, menghentikan peningkatan diabetes dan obesitas. This is the illustration of obesity case globally from 1972 to 2012, having very high increase, with a higher case were located in USA. This is the example of the data or illustration of NCD relates with nutrition status in Indonesia between 27 until 2018. For nutrition, stunting and obesity among children under 5 years old can be concluded that there is no increase, that yet it has not met expected target. And this is the view of overweight and obesity on adult in 27 to 2018 in Indonesia. It can be seen that it saw an increase, as we know that obesity is among the factor contributing to the emergence of several NCDs, such as diabetes mellitus, hypertension, and heart disease. Ini adalah gambaran 10 negara dengan kasus diabetes yang tertinggi di dunia pada tahun 2013 pada dewasa umur 20-79 tahun. Kita lihat di sini tertinggi adalah di China dan Indonesia menduduki urutan ke-7. Dan ini adalah gambaran prediksi di dunia bahwa pada tahun 2010 terdapat 285 miliar orang dengan IGT dan diabetes. Dan pada tahun 2030 diperkirakan akan terdapat 439 miliar orang dengan IGT dan diabetes, atau ada kenaikan sebesar 54%. IGT is impaired glucose tolerance means that blood glucose in raise beyond normal level, but not high enough to warrant a diabetes diagnosis. Where a higher case, where is Western Pacific. The trend of diabetes case number in Indonesia among population aged above 15 years old had increased in 2013 to 2018. Dari beberapa penyakit tidak menular, maka penyakit jantung, stroke, kanker, penyakit pernafasan kronis, dan diabetes adalah penyebab utama kematian di dunia. Di satu sisi, faktor-faktor risiko yang dapat dimodifikasi atau dapat diupayakan untuk diubah seperti penggunaan tembakau, penggunaan alkohol, diet yang tidak sehat, aktivitas fisik yang tidak mencukupi. Faktor ini kemudian dapat menyebabkan kelebihan berat badan atau obesitas, peningkatan tekanan darah, peningkatan gula darah, dan peningkatan kolesterol. The NCD trait can be the NCD trait can be overcome by improving on enhancing knowledge and utilizing the potential in its region it has. The solution can be can streamline energy, and time. Jadi faktor-faktor tersebut dapat diatasi dengan menggunakan perbaikan atau peningkatan pengetahuan dan memanfaatkan potensi di tiap daerah yang dipunyai. Solusi ini dapat mengefisiensikan biaya dan tenaga serta waktu. The NCD program and the indicator of target achievement managed by Ministry of Health, Departemen Kesehatan, Kementerian Kesehatan, mempunyai rencana-rencana pembangunan jangka menengah nasional, didukung oleh Renstranya, ada peraturan Menteri Kesehatannya, ada Permenkesnya, dan sudah menentukan indikator-indikator dalam pencegahan dan penanggulangan PTM. One of the program is Prolani Service, Program Pelayanan Penyakit Kronis or Chronic Disease Service Program. A health service system and proactive approach implemented in an integrated manner involving participants, health facilities, and BPJS, WHO suffer from chronic disease to achieve optimal quality of life with cost-effective and efficient health services. The activities include medical consultation on education, home visit, reminder, activity club, and health status monitoring. Other example of the programs is Posbindu PTM or NCD Integrated Health Service Counter atau Pos Pelayanan Terpadu Penyakit Tidak Menular, which is a health effort by the community orienting on promotive and preventive effort. Yet the result obtained has not reached managed target. Among the obstacles on the field are lack of health servant, community involvement funding, and low sustainability. Therefore, the alternative is by utilizing local potential. The research done by our team since 2016 to 2019, focusing on diabetes and obesity case, obtained several local potential to be utilized. Relate with social capital, 3 program obtained concluding that social organization focusing on or care about diabetes has not been stabilized, like Health Heart and Elder Club. This social organization actually very useful for the purpose, does need to be facilitated or motivated to be stabilized and help the effort to take care diabetes patient. Social capital like Posyandu, as shown on the tree diagram, in fact is not purely social capital since it operates under Puskesmas coordination and program. Only it operated by cadres, which is the form of community participation. This is a picture of one of Posyandu activity in suburban area. Simple yet many of the community use the opportunity to gain health service, particularly as preventive effort. The research result, new information, need to be considered in program arrangement that there has not been any social capital in the community beside Posyandu. The main culture system affecting health is habit that then form community lifestyle, relates with diet habit, physical activity, and stress management. Social system in form of family support and healthcare support are highly significant factor whether in preventive of diabetes as well as the treatment or the management. Other result from the research is healthy institution support and policy, the leadership style of social organization, partnership and informal social condition and culture, our local potential can be utilized in health program effectiveness. Local food potential in region is also a part of local potential supporting the achievement of health target. Local food is food material produced locally, as legit, affordable, and can be used as health functional food. Example, utilization of rice bran or yam flour as snack for diabetes people or to be used in preventive manner. They can be processed to be biscuit, cakes, brownies, and chip. This is a document flour brand produce, and this is document brand biscuit produce. Nutrition Home of Semarang Health Offices, an example of program utilizing local potential and support such program, was established on January 29, 2014 as an institution for malnutrition care located on Nusa Indah Street number 12 Serondol Wetan, Banyumanik. For the activity, it closely collaboration with Posyandu cadres, Karyadi Hospital, Marine and Fisheries Office of Semarang City, Nutritionist Association, Indonesia Physiotherapist Association, Family Welfare Program, NGO, and laboratory. It supported by the head or institution on top level, province, city, and region. Other example is Posyandu Nutrition Home Model, focusing on treatment of nutrition status, improvement particularly for malnutrition, and some countries has been considering obesity case. Having activity like new case finding, counseling, treatment, health promotion, food ingredients utilization. The Puskesmas remain as the coordinator and as part of Posyandu activity with the team that consists of health cadre, co-institution, school, and company. The phase of in local potential utilization in diabetes treatment, empowering social organization in the community relate with NCD treatment, particularly diabetes. Example, through Demil Gymnastic Club. Maximizing the result of Prolanis and Posyandu program by involving a community potential, like involving the collaboration school and social environment. Arranging the availability of health food on the market by supporting policy and utilizing local food and functional food. Arranging the availability of health food on the market by supporting policy and utilizing local food and functional food. Thank you for attention and terima kasih. Saya kembalikan Mr. Lukman. Back to you, Mr. Lukman.
Yes, Prof. Thank you, Professor Oktiaworo, for the remarkable presentation and the topic, because Professor Woro always did a research and community empowerment with the approach of local potential or local wisdom. Because she is from nutrition department, so she make a nutrition engineering, social engineering in nutrition to decline the obesity among people, among adults, and among children. We move to the second speaker, but before that, I will inform you to the all audiences here. You are able to ask the question by writing in the chat menu, and I will address several questions after all speakers deliver the topic. And now let's welcome to our second speaker. She will deliver a presentation entitled Health Education as an Effort to Enhance Community Participation in Environmental Disease Prevention. Please welcome Professor Nirwan Tunbul, PhD from Masarakam University, Thailand. The screen is yours. Prof. Nirwan?
Hello, can you hear me?
Yes.
Yeah, okay. Good afternoon, everyone. Yeah, I hope you are doing well. I come from Thailand, and I'm sorry, and I just land from the airport and I find some restaurant around here that they allow me to talk. Okay, just would like to share the screen with you. Lookman, could you help me to share my screen, please? Because
okay. Wait a moment, please.
Yeah, okay. Because it's probably not comfortable in here to
okay.
Right, okay.
You can see my slide.
Yes,
the slide.
yeah, okay. Yeah, thank you very much. So I will talk about how education and effect to enhance community participation in environmental disease to prevention. My talk, it probably mix everything. It's not only my research, but it's including some case study in Thailand as well. Can you move to next slide, please? The topic will be discussed at the 30 minutes that I talk. It might be include the meaning of health education, but that we need to remind a bit. I know a lot of people know about that, but we need to think about what exactly we need from the health education. I will talk about the determinant of health as well. And we'll talk about what the difference between health promotion and health education. So we'll involve to the core component to increase individuals, communities awareness to improve their health. That's, I mean, the people we looking forward to see them health like patients or even their families. We'll talk about the role of behavioral change and talk about health education media, what is suitable to use for encourage our patient or their family to get the good health. And it will be the last one will be discussed from the case study in Thailand. So as we know, if we just searching from the internet, we can see that what the health education people know about. This is from Wiki. What we think about the health education is maybe about the people learn to behave or the manner conducive to the promotion or even maintenance, the restoration of health. So however, when we talk about the health, it's multidisciplinary for definition because it's a lot of things. It is including multiple definition of health education as well. We have, can you move to the next one, please? So we use the Bible to do the health education. You know what? Who can write the Bible is from the WHO. For the WHO, that we found that health education is any combination of learning experience designed to help individuals and community improve their health by increasing their knowledge or influencing their attitudes. So for the meaning of health education, we will think about what is effect to their health. The principle of determinant of health, we talk about 6 things to think. We concern about the genetics, the biological, the lifestyles, the socials, the health behavior, the environment. This is all the component of determinants of health. For more than that, when we look at the Health of Canada website, they add more than they put from the principle. It might be effect from a lot of things. 9 components that Health Canada show. The determinants of health will include income and social status. It will be social support network. And then it will include employment and working condition. It also can be physical environment, education, healthy child development, biology and genetic endowment, health service, and personal health practice and coping skills. This is 9 components that the Health Canada have proposed for us to look and think before we apply for health education. So for the community well-being, 12 issue concern about the diagram of social determinant to make the community well-being. But this is, we need to talk more than only 6 and 9. This is 12 things that's in the detail. This is proposed by the Central Queensland Rural Health. So we think about the education, the early childhood development, the social connected, health and social service, the culture, the gender, the ethnicity, housing, built environment, the physical environment, the employment working condition, and the income. This, when we look about this, we can plan what we can do to make the people get the good health or get the community well-being. So for the 6 things we put on the detail for social dependent of health, the economic stability is the main thing that we need to think, as we can see a lot of things going on around the world now. When COVID spread around, we can see when economics not stable and it go down, and we can see will be have affect a lot of health of the people. The neighborhoods and the physical environment is one thing we think about, and the education, the food, the community, and social context. And also the main thing is healthcare system. We will talk in the detail for the next slide. The economic stability will look at the employment, the income, the debt effect a potential ability to exit and maintain healthcare service. And we can see the data from a lot of research or even the report from the news. Economic is the main thing to make the people get good health. When the people get unemployed and their income did not come for pay for excess the good accessibility to the healthcare service. That means we can see a lot of country, even they have the facility of to use the good health service. But we can see when they are unemployed and their income go down, we can see their health status is gone down also. The neighborhoods and physical environment, the patient who live or access to transportation and safety and walkability of community, this is the main thing that we need for the community health being. The education, the access to good school, provide early childhood education, vocational training option, and more opportunity for higher education. This is what we need people to get it all. The food, maybe the limit of the foods, the limited to access to the healthy foods option, the living patient to deal with hunger and food insecurity, which can create or complicate health issues. The community and social context, discrimination, dysfunctional support system, poor social integration, and a lack of community engagement, or it can contribute to stress and other damaging health effects. The healthcare system. Patients may face barriers when trying to access quality care. Inadequate insurance coverage, absence of provider with appropriate linguistic and cultural competency. This is one concern of healthcare system. So sick of this we need to think when we plan to do something for the patient or the people who we look after. And before we even plan for the health education. To the next slide, please. The importance for social determinants of health. The new survey have survey when the COVID-19 crisis come up. This is we found out the importance of social dependence, found out a consumer underestimate the non-clinical driver that impact their well-being. The majority of people have experienced a change that impact their well-being. The consumer do not know what social determinant of health information to share with provider. This the survey that report when it's COVID have been crisis. So that's the main data we need to talk when we think about the health education. Is it come with what's the health education or health promotion we will do? From the definition that I can find from Whitehead proposed about the health promotion is going to be emphasized on environmental health and socio-economic determinants. Its participatory involvement and also its media concern. But for the health education, we focus on empowering individuals. The health information and increasing awareness about health education. Community by providing information and teaching techniques to achieve better health. Relate to those activities informating individual about the cause and nature of health sickness and individuals' vulnerability attached with their lifestyle and behavior. A vital component of health promotion is health education and is concerned about media play crucial of role. This is one we need to think. The next one is we talk about the health media. Could you move, please? So think about the meaning of health education from WHO again. We need to improve the individuals and community people to get their health better by increasing their knowledge and influence their attitude. So what the tool we can use for that? Can you move, please? So when we want to use for the tool, we think about what the technique can make the people change their behavior. The core component to increase individual and community awareness to improve their health. We use so for long time as the health educator. We use their knowledge, skills, attitude, and value. This is competency. The skills means that their ability to perform a task. The knowledge, understanding of information. The motivations, attitudes mean internal driver of behavior. This is competency, demonstrate behavior that lead to success. When we know that this one will be led to success, we can use the right thing to encourage the people or enhance people to change their behavior. So the next slide, please. This is the role of behavioral change. The 5 things that we need to think about to building individual capacity. Because the building individual capacity is the main thing of health education. The health education is one thing we include of that. And also the educational, the motivational, the skill building, and consciousness rising technique. The next slide, please. Behavioral change communication. From the meaning of behavioral change communication, it will be is a process of working with individuals, families, and community through different communication channels, and to promote positive health behavior and support an environment that enable the community to maintain positive behavior acquired. 3 things this we need to use when we need to change behavior for the people who we looking forward them to get the good health. The interchangeability of health education. We have 4 things to thinking about. The education that we give it for them, the information for contact them for, and then the communication, how we can communicate with them, and behavioral change communication. This we call interchangeability of health education. So how we can change them? When we think about to change people behavior for the good thing, we look at 3 techniques. The one thing is approach them by individuals. Some technique, some topic, some education, we need to approach people by individual approach. But some might have to move to the group approach. The group approach will include panel discussion. Some health education by use panel discussion or workshop or role plays, socio drama or demonstration. What if some group can't do for the group approach? We might, if the people that the audience that we look is a lot of people, we might think about to use the mass approach. The mass approach that we learned a lot and have been used for a long time. The first thing is the television, the radio, the newspaper or the press, the documentary or films, the poster, health magazine or booklet, or even health exhibition. Three approaches of this we will pick up to use for imply for our health education. Can you move, please? So we look at the media tools that we have been learning for a long time. The media for education, we use personal media. We use print media. We use electronic media. So for the long term, we might use the personal media for teaching them by individuals or by group. We use the print media for their to keep an eye and reading all the time. We use printed, and then we use for the book or even the journal. We use electronic media. Is that seem to be more and more for health education right now. Could you move, please? Some area of Thailand, when we want to give the people education, it's okay, right? Okay,
You can continue. Sorry.
all right, it's okay. So I think it's happening all the time, so it's okay. All right, it's the when we talk about personnel, the personnel for media, the healthcare professional is a main thing. But because I said because first, because it's some people or some patient, if we use the other media, they probably can't get what information we want to communicate with them. So this sometimes from the local of Thailand, we always have the section or the corner from the hospital to teach health education before they become to do to treatment, or even some school, the health education, the healthcare professional have to plan to go to some school if they need to get the health education for the student. Can you move to the next one, please? For the print media, all the print media, we can see less and less media of this. Even we see a lot of like a print, but some print, it come with the digital, like come like from the internet, come from social media, something like that. But we always can see the print media will be good for the patient or the audience who can't access for the tech, who can't access to the new technology. The printed is also have the power for them to have to send to the rural area. So next one, please. This is one thing we think about for health educator. The health education by approach to electronics media, digital media, or we call social media now. The social media is a powerful tool which offer the collaboration between user and is a social interaction mechanism for a range of individuals. But when we look at this, social media, we have two impacts. We have positive impact and negative impact as well. The next one, please. For the positive impact, we can see how social media acceptable for the health education. The 6 key overcharging benefits were identified as, I'm sorry that, can you hear me? Because it's quite a bit noisy in this room.
Yes, you can
Okay,
continue your
okay,
presentation.
because, all right. So the first thing, the increased interaction with author, and it's more available, share and tailors information. The increased accessibility and widening access to health information for peer, social, and emotional support, a public health surveillance, and potential to influence the health policy. They have been researched and found from the JAMA journals. Can you move the next one, please? But the negative issue, I be concerned. The negative issue we found the primary consisting of quality concern, the lack of reliability, the confidentiality, sorry about that, and the privacy need to be maintained. So when we look, can you move the next one, please? So when we look at the research or the study, I pick up only one that might be important thing. But when we search from the internet, we can find lots of things that have effect from social media and affect the people lifestyle. This is a study found social media usage had increased mental health issue in teens. They found a lot of teens, they use most of them, they texting, they emailing, they checking the time, they social networking, they web searching, or even playing the game by social media. So the research indicate that, the next one, please. Can you move to the next one, please? The research had indicated that the many adults who born in 1995 or later are facing mental health issue. They found out the overuse of social media increase in depression or anxiety-related case among youngsters suffering mood disorder. They also found out the rate of suicidal thoughts increased by 47% from the last 10 years. This is the topic that we need to concern when we think about to keep the education by social media. The next one, please. So, how education media apply to Thailand? We learn from a lot of things. We look at what the topic we will give for the participant that we need them to receive our information. We use all individual approach, use group approach, or use mass approach. I think they are same to every country, but we use this in the case to show in Thailand, because the main concerns using the media is the audience. Some audience or participant, we can't use mass approach for them. We can't even use the group approach. They might happy to use only individual approach. This next one, please. So this would come from my research. My research go to a local community in Thailand, near where I live, in the northeast of Thailand. Which is, if we compare the area in the Thailand, my area is quite poor area because it's in a dry area, not smart rain. This is the case study I found. the population income in the mine research area is below the poor line of the average income for Thai. And also we found the level of adult education is at primary school and under. So as we think about to apply health education, which way for the good to apply for them to get our information or get our communicate and can communicate with them. For the next one, please. Sorry, that's I use in Thai because the reports are in Thai. The case study is from the local. We use the song. This is the case of dengue. Dengue virus is also the high epidemic in Thailand. It's also so dangerous along with the COVID-19 right now because it's a raining season. The local healthcare professionals we found using only individuals approach, it can't be coped with this. So we use the mass media. They create the local song to encourage local community to protect dengue virus. If you can want to listen, they use for in Thai, they call in the Isan area, we call Mo Lam, is a local song. This mass media is application using for the digital media. But I'm sorry about we limited the time. I can't show what they do with this. So what you can use the link to see what they do. We mix a lot of things together. Right, so next one, please. So for the mixed media approach for dengue prevention, it's not only mass media. All the country have announced from the Ministry of Public Health. We use 3-3-1 rule for dengue prevention. We use 3 hours, first 3 hours, second 3 hours, and the 1 hour last. So the rule called 3-3-1. The first 3 hours, when we found the doubt case, we need to report, and the healthcare professional will report in their form of their format. And then after 3 hours, for the second time of 3 hours after that, healthcare professional, we go into the field work. It might be a house that we found the case. They will go to the field work and give health education to teach the people who live in there, and also spray the mosquito around the house that found a case. But after the 3 hours, when the 1 hour left, the local community have to call for the meeting. We use the group approach to do the workshop about that. If the environment around the house, around the village, or the area around there is not suitable to live, or it's suitable for the mosquito to lay the egg. So we work on with that, have the workshop and work together. In this last 1 hour, we also do the surveillance for 20 days as well. So this is the rule of 3-3-1 rule for dengue prevention, that we mix media together to control the dengue virus. For the next one, please. This is for the field work they do for the community. Even we are the same country, we have rain a lot, and then if they have leave the pots thing around, might have to tell them to have it dry or to clear up of the larva of the mosquito. And the healthcare professional will use all spray for kill the mosquito. So next one, please. So the one thing that they use the digital media apply to educate patients and their relative. Might be that we use the mobile application, we use like a GIS, we use the correlation stress, we apply from the dog art enhance to scan the patient face to see how they get the uh, dengue virus. The next one, please. This the paper from Thailand in show invisible facial flushing into case of dengue infection and influenza detected by PC program and smartphone application. The decorrelation stitching and chemical touching that we use. This is also the one media that we use for healthcare professional and also the patient who want to know about this, how it different with when they're using the mobile application. Next one, please. In the local community, sometimes this is a case of liver fluke program. We use health education program. We call the program because it comes with a lot of things together. Right, the first thing we set up the health education program using individual approach, because when we think about health education, individual approach is the main thing that we should refer. We use it by personal health education, including knowledge and to, to influence their attitude and to hope to change their practice. So the theory of KAP or knowledge attitude practice is used in the health education program. So after that, we use the expectation about the prevention of liver fluke disease. We use the form and encourage them what their expectation to prevent it. And we also use the technique of intention on prevention of liver fluke disease and monitoring of home visits and other official public health. They receive information on prevention of liver fluke or liver fluke or liver leaf through the village broadcasting tower. But for the local community, the broadcasting tower is also the good media that we use for the mass media. So the healthcare professional in that area have to have the schedule to give the health education so they can broadcast in the village so people can hear. And also we always use the print media to make like booklets or the book and the paper sheet for them to remind what is the danger of liver fluke. The next one, please.
Sorry,
So,
Ajahn, it's only 3 minutes left.
Oh, okay, sorry. The community health literacy developing process in liver fluke. This we use the 9 steps. This is a research from my student and found the area context and situation, the first thing we do. The community health literacy action plan development and prevention training program that we do for the people who we are audience, the campaign program, the community participation network development, and follow up and supervision, implementation support, community learning forum, and also lesson learned to show on effect on preventing liver fluke in the community. The next one, please. So this the nutrition promotion program to reduce the sugar, fat, and salt intake, applying cell recurrent and family support among patients with type 2 diabetes. This is in the case of NCD. We use 12 weeks program with 6 times to do things. The first thing use health education individual again by using the knowledge of nutrition. And then the week third, we do practice how to choose the suitable meal using plate pallets. And the week 5, using social support to monitoring meal and their family. And the week 8, we use social support by follow-up with healthcare professional and their family. Week 10, social support by telephone reminding for the right nutrition by healthcare professional. And week 12, using evaluation form for conclusion the program. Next one, please. So for the last one, the case study for Thai, we are really happy that in our country, we can control the COVID virus. But in some area, we have still have some curfew, but we can travel around or going out from our house at the moment. Because in Thailand, we set up the Corona Epidemic Situation Management Center. So every day, this center have to report what's going on about COVID in the country. And also we have social media. It's the lots social media have been the reports about what happened, what the event in the country. And also we have really appreciate village volunteer supporting and also have state quarantines. The next one, please. The Health Village Volunteer is a case study for doing controlling COVID for Thailand. So sorry for the in Thai, we get the really appreciate from the WHO to tell us we use the right thing. The health will the village volunteer, the health village volunteer who supporting for protecting the COVID. They all work, always the people from the village, but they have been training, they have been teaching what they can do, and they also help for healthcare professional to deliver something that when the people have to do the stay in their home. So from the case of this is the main that we need to talk on the health education when we look at the audience and the limits of the media to use this. So I think it's a come for the conclusion. And I thank you for your attention. So what I happy to talk with you is all the health education we need to think is our audience or our participant. And when we look at them, we need to think what we concern. A lot of techniques and a lot of tools we use in Thailand that I can show. And thank you very much for your listening.
Thank you very much, Ajahn Nirwan. Thank you very much for all speaker, Professor Oktiawara and Professor Nirwan, for your interesting and informative talk. I think both topics will provoke us to ask the questions. Very well, ladies and gentlemen, now we come to question and answer session. On my notes, I have several questions obtained from chat menu and from YouTube. I will address it to the speaker one by one. First question to Professor Oktiawara. The questions from Mr. Siddiq from Semarang State University. The question is how to empower the community to be actively involved in each program and support it until the end, organized by government or local community organization. Please, Professor, to answer the questions.
Yeah, thank you, Mr. Lukman. And thank you to Mr. Siddiq Purwoko from Universitas Negeri Semarang. The improving it's not only from the community, but also all the subject or the department must be giving their hands or give their cooperation. And of course, it's according to its capacity. In this time, the role of leader or head in policymaker in its level very determinant. Sebagai penggerak adalah, saya katakan tadi, adalah pimpinan di institusi. Misalnya leader from puskesmas, atau pimpinan di masyarakat, misalnya ketua kader, dan pimpinan penentu kebijakan ini harus mempunyai mitra-mitra yang dapat diajak kerjasama. Kemudian petugas di lapangan terkait, misalnya untuk bidang gizi, maka penanggung jawab bidang gizi di lapangan ini juga harus mempunyai hubungan yang baik dengan kader-kadernya. Selain itu, selain ada hubungan yang baik dengan masyarakat, dengan kader, maka mereka juga harus jeli mengambil potensial-potensial yang ada di masyarakat. Apakah berupa kebiasaan masyarakat, misalnya kebiasaan dalam konsumsi makanan. Mereka biasa mengkonsumsi susu, produk dari sekitarnya, lingkungannya. Ini merupakan potensi yang kebiasaan yang bisa dimanfaatkan untuk perbaikan status gizi. Atau potensi lainnya adanya modal sosial, social capital. Misalnya tadi posyandu, kemudian klub jantung sehat, atau kapital sosial lainnya. Kemudian ada lagi potensi bahan pangan lokal dan fungsional. Seperti bahan pangan tadi yang berupa bekatul atau brand yang mempunyai olahannya mempunyai indeks glikemik yang rendah, menyebabkan kenaikan gula darah yang lambat dibandingkan dengan bahan-bahan pangan lainnya. Ini merupakan potensi yang dapat dimanfaatkan. Kemudian potensi institusi mitra. Misalnya adanya perusahaan di lingkungannya, adanya sekolah-sekolah kesehatan di lingkungannya, ini juga merupakan potensi. Tentu semua ini harus ada dukungan dari pimpinan. Saya tekankan di sini harus ada dukungan dari pimpinan, baik itu di tingkat institusi kesehatan, di tingkat masyarakat, pimpinan kader posyandu misalnya, kader kesehatan, di tingkat institusi mitra, kalau dia bermitra dengan perguruan tinggi kesehatan, maka pimpinan institusi mitra itu juga harus bekerja sama, harus mempunyai kemauan, motivasi untuk menjalankan program ini. Jadi tidak bisa masyarakat itu sendiri bergerak, tetapi harus ada dukungan-dukungan semua yang terkait. Itu mungkin yang bisa saya sampaikan, saya kembalikan. Thank you Mr. Siddiq and back to Pak Lukman.
Thank you, Professor Oktiaworo. If I can make a translation from Professor Oktiaworo said that the important role is from community leader, like religion leader or respectable people that they are from the community, local community, and it should be fully supported by the leader, or the staff or the community can analyze the potential or social capital from the community, like what Professor Woro said, that from like integrated health post to monitor health body weight from among children, and from local food or substitution food, and the last is from support from the institution around the community. For example, from corporate social responsibility from the institution around the community. Okay. Next to the second question, to Professor Nirwan. The question also from Mr. Sidik from Semarang State University. The question like this: in this pandemic situation, what is the appropriate media to enhance health literacy among people?
Right. Okay. The situation right now, I just use the case of my country. Yeah. It also what we don't know what the best one. It depends on the audience of area. Around the area, the local community that I can show the best thing that we should help volunteer to have the education for them. And for the all around country, we use the mass media, television. We know everybody watches television, so we report all the time and give even health education. For the some group that people who live in the town, we use social media. You know what the social media is limited for someone who live in the local community, but it's someone who like people like us or the people in the town, they also, or even the younger, they can use that social media. That's what is my answer.
Okay, thank
Okay.
you for your
Yeah.
answer. And next question from our friend from Philippines, from Ferolino. He's from Mindanao State University. His question is to Professor Nirwan: what kind of application you develop and use in detecting those kind of disease? Can we also use it in detecting the COVID-19?
I'm not sure. We not use that, but we use the for the application. We use for NCD, the main things. A lot of things I use from the NCD or liver fluke. Yeah, but we haven't thought about the COVID-19. But we use the application for the warning for just only for the healthcare volunteer to use for their report. It's not for, and for the health education. It's not for the what's for the treatment or something like that. We don't use in that state yet.
Okay, last question to you, Professor Nirwan.
Uh-huh.
The question from Fitriana from Semarang State University. It's interesting question. The question is how to increase people believe about COVID-19, especially for lower educated people, about new era or new behavior or new normal like this. Or you can share about the best practice in Thailand to control the COVID-19.
We have to tell them what exactly happened. Show them what exactly happened. Don't hide anything. What we may have to show the picture, we have to show the how dangerous is to their health, and show them how people going to die, what happened in the severe country, how many statistics, show the statistic that people have been died and how they suffer. That's the main thing for the local people. Use the technique like this, they're concerned and the awareness of that. That's what we use for treating the health volunteer, the village health volunteer to do this for the local people. And they scare each other. You see, when the different areas, such as if the people, because in the town they happen for the COVID, the Bangkok people, when they go back to their hometowns, like local people around my area, they have to go to state quarantine. All the people in the village, they watch each other. They're really careful that when they're concerned about how the dangerous of the disease is. That's what we need to do. Tell them exactly and even show their statistics, what's going to be happen and how people die from this. That's what
Honestly, is very important.
Yeah, yes, it is. It is, yeah.
Unfortunately, we have to end the second plenary session, which
Okay.
means the whole plenary session has ended. I'm so sorry. In my notes, there are so many questions, 100 questions in YouTube and chat menu.
Okay. You can send by email if some question is about me.
Okay,
Yeah.
okay.
Yeah,
Okay,
okay, thank
but
you.
before closing, let me read the conclusion of the second plenary session. First conclusion is non-communicable disease case can be passed down by local potential or local wisdom approach based on community characteristic like integrated health post, community empowerment, health volunteers, and social capital. Social capital, like Professor Woro said, and social determinant of health has important role to develop community well-being, and behavioral change steps start from health education, education background, motivation, skill building, and raising the consciousness from Professor Nirwan. And to all audiences, please pay attention. I will show you the slide. On the screen, it is the link of attendance and evaluation form of ISPHE 2020 for issuing the e-certificate. You can click gg.gg/ISPHE 2020. Can operator make a copy to the chat menu so it can be copied? And please write your email address correctly. The e-certificate will be sent to your email address. Make sure your email address is correctly, and the link is active for only 60 minutes after this plenary session is over. You can click gg.gg/ISPHE 2020. Anyone of operator can write again in the chat menu so it can be copied. Finally, we come to the end of the session. I would like to say thanks again for Professor Oktiaworo, medical doctor, and Professor Nirwan from Bangkok, from
Okay.
Masarakam University. And sure enough,
Yeah.
to the audiences for your active participation. I do apologize for any imperfection as a moderator. Hopefully this session will be beneficial for everybody. Thank you for your attention. Good afternoon. I give the next agenda back to my college assistant professor Suraya.
Thank you.
Thank you. So I
Thank
can leave
you.
now. Thank you very much.
Thank you,
Thank you,
Prof.
Ajan.
Nirwan,
Thank you.
so much
Bye.
for
Thank
joining
you,
us.
Prof.
Okay,
Oktia.
bye.
Have a safe flight.
Thank you. Oh yeah, I just landed. Really. I am in Bangkok now.
Okay.
Okay.
Good.
Right. Thank you. Bye.
Okay. Okay. Thank you, Mr. Lukman Fauzi, and all the invited speakers, Prof. Oktiaworo and Ajar Nirwan, for the wonderful presentation and discussion. May it advance our knowledge and may it strengthen our collaborations. Ladies and gentlemen, we would like to re-inform you again to please change your Zoom account name according to the assigned room as we have announced in tag and email broadcast. You can see the example in my name here, D/MC Fatona Suraya. You can write your alphabet and then underscore your full name. Please change it now because our operator are trying to break out the room after this. All right. So it is the end of the plenary sessions. Approaching to the next agenda is parallel sessions. I'd like to inform you that you will be directed to a parallel room that you have been chosen before in the second registration link. You will be directed to a parallel room that you have chosen before in the second registration link. May I thank you very much for your active participation in the webinar of the 5th International Seminar on Public Health and Education 2020. I apologize for any mistake. Thank you for all the speakers, all the committee, presenter, and participant. I hope you enjoy the program and get fruitful knowledge of the webinar. At last, I hope you enjoy all the agenda until the end. Have a nice oral presentation. See you next time. And wassalamualaikum warahmatullahi wabarakatuh. Ladies and gentlemen, we need a couple minutes for breakout the room. Please enjoy the program while waiting for breakout room. All the presenters are going to present paper. Please keep stage attention because there will be a question and answer session in the parallel room. So for all presenter, please stay tuned and we are going to direct you to your parallel room and there will be question and answer session after your presentation. Thank you. Please enjoy the video while waiting for the breakout room. Thank you.
ada banyak kesempatan bagi seluruh mahasiswa untuk menjadi yang terbaik.
Okay, tes. Can you hear me? Halo?
Yes, I hear.
Halo, tes. Is it okay?
It's okay. I share you.
Okay.
Belum. Tutup.
Is there Mr. Joni Siahaan?
Udah.
Hello? Is Mr. Joni Siahaan here?
Ya. Biarin aja. Aku tadi bawa aku celana pendek. Aku tadi itu lagi makan. Waduh, ini udah waktunya ya. Baru berapa suap, aku tutup makannya. Aku masuk kamar ganti baju.
Halo, halo.
Oh, I'm listening.
Is there Mrs. Sutini?
Are you calling my name?
Are
Excuse
you
me?
Mr. Joni Siahaan? Are you Mr. Joni Siahaan?
Hello, I'm Mr. Nawan.
Siapa iki? Iki delok-delok iki ben carane iso nonton kabeh ngono piye ya?
Halo Bu Widya.
Halo, iya.
Pembagian ruangnya gimana Bu Widya?
Bu Heni harusnya tidak di sini.
Yang ngapain juga
Di mana saya?
Saya enggak tahu. Sebenarnya.
Ya, makanya.
Depannya diberi huruf
Yang
ruangan.
ya nama apa ruangan dulu Bu Heni atau Pak siapa tadi Pak Hermawan itu ruangannya misalnya ruang I ya I_Heni gitu. Yang membagi yang pusat iya saya nggak bisa bagi dari sini.
Oh gitu.
Ada di website
Ya.
Oke, aku bantu.
Pak Hermawan itu silakan di rename. Pak Hermawan masuk di ruang berapa? Saya enggak tahu Bu Heni.
Ini ya.
Saya
masuk di mana?
Ini underscore gitu ya.
Iya. Pembagiannya di ruang apa? Ya, oke. I Heni, oke.
Ipang.
Ya, ini ya, nahan ini ya, terima ya.
Ipang ikut mana?
Telepon ini ya. Ya.
Iya.
Pak Ipang?
Ya.
Pak Didi di rename namanya dulu kasih underscore Didi Rinan Sumekno gitu ruangnya.
Oke.
Oke, udah. Terus mati kan tahu sendiri di sini. Endut.
Jamnya sih. Ya. Iya. I did it. Sudah pindah, sudah rename kok. Ruang depan nanti.
Oke, assalamualaikum warahmatullahi wabarakatuh. Sorry, please
turn on your camera and off your microphone before
Ini
we start.
apa? Halo, I'm Junaidi. Room. It is room. I'm sorry. It is room. Hello, Miss. Just a minute. I start to join you. I chose room. I'm Junaidi. It is room.
Wait, Mr. Still on
Junaidi.
process. Still on process, please.
Yes.
Okay. Mr. Junaidi, please your
Yes.
rename, please. Rename, please.
Rename, please.
Junaidi Hamid. Yeah.
Yes.
Please
Yes.
rename your mod. Yes. Okay. Gege Muhammad Arif Ali, please rename. Mr. Junaidi,
Yes.
please to rename your Zoom.
Just a minute. My stuff there. Yes.
Excuse me, what should I rename this account? Is it E_Junaidi or?
Halo, Pak Wadi.
Halo.
Moderatornya siapa Pak ini Pak? Moderatornya siapa?
Embo sapa kuwi? Said Junaid Said apa Mr. Said itu
Aku arep takon aku bener ning kene apa ora ya?
Makanya aku pindah ruang songo piye maksud iki ya?
Nah, Miss Maria.
Mr. Hermawan Pamot, please be patient
Help me.
because this is on process.
Oke.
Halo. Mas Rano. Halo Mas Rano. Halo. Halo Mas Rano. Sumber rekaman. Halo Mas Rano. Halo Mas Rano.
Bu Putri, saya ada di mana Bu Putri? My room, where my room, Bu Putri, please help me, help. Help me please. Where is my room?
Mohon izin Pak Hermawan, saya menjawab. Ya.
Halo, Pak Azam.
Mohon jenengan dirinan dulu sesuai dengan kelasnya. F-nya besar, underscore, kemudian Hermawan Pamok Raharjo. Itu cukup membantu kami, Pak. Ya, F besar, kemudian underscore.
Oke.
Ya. Untuk rename-nya itu diklik kanan sebelah atas, bisa
F besar ya?
Iya, underscore. Hermawan Pamok Raharjo. Itu nanti membantu operator untuk memasukkan ke room-room yang akan dituju.
F besar. Slice
underscore bukan slice. Garis bawah, Pak. Yang lainnya juga sama, yang mendengar suara saya, yang ingin masuk ke dalam Zoom yang dituju,
Suaranya pelan sekali.
Formatnya ada di chat, Pak.
Gimana Pak?
Formatnya ada di chat.
Bu, saya di WA.
Permisi, saya sudah dari tadi.
Dengar. Halo?
Boleh nanya, Mas?
Nggak dengar.
Silakan. Saya cuma membantu saja, monggo. Silakan yang mau bertanya.
Iya, saya di ruang E. Ini kalau nama saya sudah E_ Nawan Primasani, berarti harus menunggu dulu ya?
Iya, menunggu dulu. Ini dari operator masih memilah-milah dikarenakan tidak merename secara pribadi.
Oh gitu.
Ya.
Nah, makasih.
Mohon menunggu ya.
Oh,